फिर दिखा दे एक बार फोटो, ये वाली क्लासिकली टीम 11, yeah. This X-ray finding is most likely seen in which infective condition?
Clostridium difficile.
Well, बिल्कुल ठीक है, आंसर इज करेक्ट. दिस इज इनफैक्ट अगर आप देखें ट्रांसफर्स कोलोन एनलार्ज हुई पड़ी है, टॉक्सिक मेगा कोलोन, and that we see in pseudomembrane colitis as they said rightly. Now, the transverse colon के अंदर we take standing X-ray. Now the question open to everybody. What is the diameter, transfer diameter we take to diagnose transfer colon का कितना diameter होना चाहिए? More than how many centimeter? 6 centimeter. So 6 centimeter से ज़्यादा we toxic mega colon बात करते हैं. And classically जब toxic की बात आती है, we talk more in relation to ulcerative colitis, to be more precise. Okay. Well, तो जो बात कर रहा था मैं आपसे, is loss of hostration, transverse, and pseudomembrane colitis complicated by toxic megacolon. Okay. Question for the audience also, open, anybody can answer. The bite of which parasite? In fact, this question came last year. NEET SS का सवाल है, वहाँ से लिया गया है. The bite of which parasite can cause weakness of lower limb, just like Guillain-Barré?
Any from the audience?
Question for audience. Anybody can answer.
No team.
पहले for the audience. Yes, sir.
Yes, sir.
Tick bite.
So
Give a big hand to tick bite.
Give a chocolate to.
So extra learning point. Clinical feature of tick bite are, इसमें Guillain-Barré की तरह preparation होती है, लेकिन it is a asymmetric leg weakness. और इसके अंदर when you are getting Guillain-Barré syndrome type picture with unilateral, think about tick bite. और इसके अंदर you have to search the this tick and you remove, you should do toxin, so there will no fever, and you have to remove the parasite, and patient become all right in a couple of hours only. Yes, sir.
Right, sir.
So this is the end of round 1. So let's see.
So let's see on all the marks, Dr. Nitin.
Okay, the end of round 1. Team 1 has scored 10 points. Team 2 has scored 10 points. Team 7 has scored 10 points. Team 9, 10 and 11 have scored 10 points. The rest of the teams have to still open the account.
They will get lot of opportunities to score.
Yours is? Team 5, I think your answer was wrong.
We answered Chagoma. Chagas disease.
Chagas disease.
अच्छा तो okay.
Correction.
कोई बात. Okay. So scoring or no scoring matters nothing, but it's a learning platform. Round 2. Team 1. This is seen in which condition? Team 1.
Toxoplasmosis.
Toxoplasmosis is the correct answer. Ring enhancing lesion by toxoplasmosis that we commonly see in HIV patients. Team 2. Which rickettsial disease can cause this lesion?
Scrub typhus. Scrub typhus.
Say it again.
Scrub typhus.
Scrub typhus is the correct answer. Scrub typhus. कुछ extra learning point भी हो जाए. Causative organism is rickettsia sutsugmushi. HR के अंदर punched out lesion ulcer covered with a blackened scab which indicate the location of the mite. Team 3. This is a cut section of the gastrocnemius muscle, larva of which organism is seen in which this patient? Yeah. Okay. Well, the answer is Trichinella spiralis. It's a nematode. Okay. The clinical muscle pain and periorbital edema is the classical finding that we see in Trichinella. Team 4. Strongyloides tuberculosis can cause which major problem in the lungs? Loeffler syndrome, no, pulmonary arterial hypertension. This question should not be missed. This question come in every alternate year in NEET SS exam. PAH, pulmonary arterial hypertension. Okay? So which murmur, again, extra point, which murmur you can see in a case of pulmonary arterial hypertension? Pulmonary regurgitation, so-called Gram-Steele murmur. Well, this extra learning, spondylitis, ये आपको भी आना चाहिए. Team 5. ये आसान है, I think, it's a bit easy question. Diabetic patient having pain and discharge from the ear with high-grade fever. Most likely causative organism is
Pseudomonas.
Huh?
Pseudomonas.
Pseudomonas is the correct answer. This is malignant otitis externa. An extra learning point is, and classically, they say if not treated, any Pseudomonas infection is fatal. This can be fatal. And you treat by aminoglycoside and third generation cephalosporin, classical thing. Another important infection is the rhinocerebral mucormycosis, जो कि COVID के अंदर भी था. Team 6. A patient has fever, headache, altered sensorium, MRI is this. What is your diagnosis?
Team 10
HSV.
Herpes
encephalitis.
simplex is the correct answer.
Very good, very good.
Okay, good. तालियां बजती रहनी चाहिए. Herpes simplex, and we treat by what? Which drug? Is cyclovir. Team 7. Endoscopic finding is seen in which infective condition? It's a beautiful question.
Pseudomembrane colitis.
Well, the answer is it's not correct answer. Answer is Whipple disease. Whipple disease, distal duodenum with whitish yellow plaque representing engorged lymphatic vessel. Sometime found in classical Whipple disease is the answer. Okay? Or Whipple disease is the one, it's a systemic disease which involves many other organs, including brain also, where dementia can be there. Team 8. Which bacterial infection can cause this skin lesion, especially in a child like this? It's a straightforward. Quickly. No? Okay, no problem. Staphylococcus. Scalded skin syndrome, SSS syndrome. Okay. Now, a question open to the whole. All of anybody can answer. कौन सी एंटी ट्यूबरकल ड्रग है जो स्टेफाइलोकोकस के अगेंस्ट भी काम करती है? Rifampicin. Rifampicin is the one drug which act against the this staph also. Team 9. Which antibacterial drug can cause methemoglobinemia?
Sulfur drugs.
No, no. Answer is Dapsone. Classical question है ये वाला. Team 10. What is seen in the echocardiography of this patient? I think ये बड़ा थोड़ा सा easy question है, I think. हाँ जी, हाथ तो खिलाएंगे. Infective endocarditis the smart answer. अब infective disease है कार्डिको तो इन्हें वही होगा. Coronary artery disease तो होगी नहीं. तो give a big hand to the intelligent person. So well, he's correct. So anyway, एक और सवाल, कौन सा क्राइटेरिया यूज करते हैं इसकी क्लासिफिकेशन के नाम? ड्यूक्स क्राइटेरिया. ड्यूक्स क्राइटेरिया में इकोकार्डियोग्राफी फाइंडिंग और द कल्चर. Team 11. This type of cervix seen in which infective condition?
Trichomonas vaginalis.
Correct answer is correct. This is strawberry cervix seen in trichomoniosis. Good, correct answer. Now question for the audience. Which is not a part of classical triad of UTI symptom? And what I want, even those who are taking part, you should also write, at least think कि क्या answer है.
Raise the hand first.
हाँ, raise the hand first आपको. Yeah. है? Fever. Fever. और कोई answer? Anybody else can try. He says fever, which is not a part of classical triad of UTI symptom. Well, the answer is correct. Fever is the answer. Fever is not a part of UTI. Frequency, urgency, and dysuria are the classical, but fever is the most common wrong answer. People, okay? So remember, frequency, urgency, dysuria is the classical triad of UTI. Fever. Round 3, इसमें we have a set of 3 questions. Okay, yeah, score बता देंगे बिल्कुल.
So after the round 2, the scores are team 1 20 marks, team 2 20 marks, team 5 is at 20, team 6 at 10, team 7 at 10, team 9 at 10, team 10 at 20, and team 11 at 20. And team 8, 4 and 3 still score.
Don't worry, marks are not important, learning is more important. So don't get discouraged at all. तो 3 सवाल, हर एक सवाल आंसर 10 marks. In HIV, team 1, which enzyme help in entering proviral DNA into the host nucleus? कौन सा enzyme चाहिए होता है?
Integrase.
Well, the right answer is integrase. The correct answer. You get 10 marks. अभी आपके पास 2 क्वेश्चन और आएंगे. Name any 5th generation cephalosporin. Team 1.
Ceftaroline.
Answer is correct. Ceftaroline. और इससे ब्रॉड स्पेक्ट्रम इसकी मेन एक्टिविटी होती है रिगार्डिंग स्टेफिलोकोकस इंक्लूडिंग वेंकोमाइसिन रेजिस्टेंट स्टेफ आल्सो. द आंसर इज करेक्ट. Which bacteria causes Lyme disease? Team 1.
Borrelia burgdorferi.
Correct answer. Borrelia is the answer. Team 2. Specific antigen for diagnosis of scrub typhus in Will Felix testis.
OXK.
OXK is the right answer. Extra learning. OX agglutinin are found only in scrub typhus. The test is negative in rickettsial pox and Q fever. One more question. So this is the typical, this everybody should know. Okay? Only thing what I can OXK scrub typhus. Again, आपके लिए which of the first line antitubercle drug?
Rifampicin, sir.
Rifampicin. Very quick answer. Yes. Correct answer. An extra learning point is effective against staph, prophylaxis or meningococcal. लेकिन एक बात जो नहीं पता होती, it is also used to treat itching in primary biliary cirrhosis. इसमें भी use करते हैं. This is something which people are usually not aware. In HIV, which drug is integrase inhibitor in HIV? Try. There is no negative
Sir,
marking.
dolutegravir.
Answer is Reltagravir. आपने क्या बोला?
Integrase.
नहीं, वो नहीं. Okay, the answer is Reltagravir.
Sir, all gravirs.
है?
All gravirs are integrase inhibitors. तो हम dolutegravir बोला था.
Okay. अच्छा, वही मैं कहूँ कि all, चल ठीक है. All gravier. चलो ठीक है. मैंने पहले कहा था. In case of any distinction, बैठे हुए लोग.
जज का पैनल.
In fact, that's why मैंने repeat के लिए कहा था. I could not understand कि आप क्या बोले. Anyway, extra learning point. ये आप सबको आनी चाहिए slide. वायरस की एंट्री होती है. रिवर्स ट्रांसक्रिप्टेस, इंटीग्रेस और यहाँ पे इंटीग्रेस का रेल्टाग्रीर, प्रोटीएस का इनिबिटर एंड दिस स्लाइड और ये जो साइट ऑफ एक्शन ये वाला है आरएनए. सिंपल टाइम नहीं मेरे पास. ये स्लाइड दिस शुड बी इन योर फिंगर टिप्स. ओके, अगेन लवली स्लाइड. मैकेनिज्म ऑफ पूरी फार्मा HIV drug has been squeezed. I wish I have more time to teach you, but अभी नहीं. Team 3, हाथ खड़ा करेंगे. Team 3, yeah. This key lesion is seen in which infective condition?
Erysipelas.
Eh?
Erysipelas.
Answer is Lyme disease. Lyme disease caused by spiral ship bacteria. टिक्की से और इसमें एरिथमा माइग्रेन्स. लुक इनटू स्लाइड अगेन. टिपिकल इसे जो बुल आई पीन्स वाली. एरिसिपेला में ऐसा नहीं होता है. ओके, सो कॉल्ड बुल्स आई पैटर्न इज सीन, नॉट एरिसिपेला. बुल आई का नाम रेटिना में भी आता है. टेल मी एनी का कंडीशन विच लीड टू बुल आई इन रेटिना. क्लोरोक्विन इज द आंसर. Correct. Question, एक और question. What is the mechanism of action of sofosbuvir? Answer is RNA polymerase inhibitor. जितने भी ब्यूवीर हैं, they are all RNA polymerase inhibitor. एक और सवाल. What is happy hypoxia in COVID? Answer is sudden fall of PaO2 in the presence of near normal SpO2. Suddenly, जितने भी पेशेंट का बैठे बैठे मरीज की डेथ हो गई, all happened fall of PaO2. SpO2 normal था. This is classical. अब एक क्वेश्चन again for all the participant. ये what is hypoxia, what is hypoxemia, इसमें क्या फर्क होता है? Only for the, no, not for the learned professor like you. Only for the participant I said. आप तो महान हैं, आप तो हैरिसन के ज्ञाता हैं.
Hypoxia.
हाँ.
Hypoxia is.
कौन बोल रहा है? Who's saying? Yeah.
Hypoxia is any condition where the tissue does not receive enough oxygen. So hypoxemia is just decreased oxygen levels in the blood.
Well, hypoxemia is PaO2 less than 60. और hypoxia when tissue are not getting oxygen is hypoxia. ये SpO2 ये क्या चीज़ होती है?
SpO2 saturation. So
What do you mean by saturation?
Peripheral blood में कितना % hemoglobin
No.
is?
Yes.
How much?
मान लो lungs के अंदर 100 hemoglobin आए, 100 ने ऑक्सीजन ले लिया, तो SpO2 will be 100. Peripheral tissue में जाके उसने 30 ऑक्सीजन दे दिए, तो SpO2 goes to 70. How many molecule, simplest language में कितने molecule of hemoglobin are carrying oxygen is SpO2. और PaO2 is a partial pressure. Okay, so all these three terms are different. This you should know. Team 4. First question. We are getting a solitary large ulcer in the lower end of esophagus in HIV case. Most likely diagnosis. Team, हाँ जी.
CMV.
CMV is the correct answer. Extra learning point. Red इसके CMV के अंदर you classically you get cottage cheese and sauce appearance in the retina also. CMV retinitis. Well, next question to you. Episodic rise of SGOT, SGPT is seen in which type of hepatitis? Episodic rise. Quickly, quickly. ये तो easy है यार.
Hepatitis A.
A is the most common wrong answer, but don't worry. Answer C है. Hepatitis C is a one topic जिसमें you will be getting a lot of questions from DM entrance also. Extra learning point about hepatitis C. Anectic hepatitis. Patient may or may not have jaundice. Cryoglobulinemia. ये line नहीं भूलनी है. Patient may have lichen planus and porphyria cutaneous tarda. Question for the participant. और कौन सी liver disease के अंदर porphyria cutaneous tarda होता है? और क्या? Hemochromatosis is the, but the better answer is liver. Hepatoma is the classical question where we get porphyria cutaneous tarda. Question 3. Which causative organism is which causes emphysematous pyelonephritis? E. coli is the right answer. Okay, classically seen in diabetic patient, you get perinephric gas for seen in this gas. Okay, and this is E. coli, this is potentially fatal. They are usually resistant to antibiotic, even you may have to go for nephrectomy also. Okay? It's most commonly seen in diabetic patient. Team 5, हाथ खड़े करेंगे team 5 वाले? Yeah. Biochemical relapse occur in which type of hepatitis? Quickly.
Hepatitis B.
No. It's hepatitis A. The clinical relapse and biochemical relapse दोनों type A में होते हैं. Serum sickness type B में होती है. Anictic hepatitis C में होती है. And fulminant hepatitis in pregnancy is E में होती है. ये सारे unique questions हैं. Second question for you, Ponset disease related to which infection?
Tuberculosis.
Tuberculosis is the right answer. And this is typically patient come with joint pains. Joint pain करके आएगा patient, and it sometimes it may really confuse the patient, maybe keep on going to rheumatologist or orthopedic wala, and that's why sometime diagnosis is missed, and the tuberculosis should be kept in the mind. Question 3, a patient is being treated with antibiotic linezolid. He should be given which supplement of vitamin?
Pyridoxine.
Yes, answer is correct, B6. B6. Now, question for the participant. Tell me in which condition, classically, B6 deficiency lead to which type of anemia? Which type of anemia is specifically due to B6 deficiency? Sideroblastic anemia is the right answer. Okay, the sideroblastic anemia is needed for the synthesis of delta aminolevulinic acid, the right answer. And in which endocrine condition we can get sideroblastic anemia? Question for the participant. In which endocrine condition we can get sideroblastic anemia? Hypothyroid. Team 6, हाथ खड़ा करेंगे? Yeah, team 6. First question. Gallium-67 scan is done to diagnose which infective condition? Well, answer is pneumocystis. Pneumocystis, classically immunocompromised. Now, एक और सवाल. Which anti-tubercular drug can be given in full doses in a case of CRF?
CRF renal failure, sir.
हैं?
CKD chronic renal failure पूछ.
अरे मेरे दोस्त, उसमें TB हो गई है, तो कौन सी medication we can give in full dose?
Rifampicin.
Rifampicin is the right answer. You can give. Now, extra learning point. Pregnancy के अंदर we can give HRE, और jaundice में we can give ENS, are the classical drugs that we give in tuberculosis. Well, एक और question. Most common bacterial infection in a patient of 1 year having cystic fibrosis.
Pseudomonas.
No. Staphylococcus. बच्चों में स्टैफ होता है, बड़ों में सुडोमोनास होता है, इसलिए ये ट्रैप है. ये ट्रैप है. दैट्स व्हाई क्लासिकली 1 year एक लिखा गया है टू ट्रैप यू. एनीवे, आई थिंक द न्यू लर्निंग पॉइंट व्यू, छोटे बच्चों में स्टैफ होता है, बड़ों में सुडोमोनास होता है. ओके, टीम 7. टीम 7. Which rheumatological condition can occur in epidemic form? अब आप पूछेंगे ये कहाँ से आ गया क्वेश्चन? Quickly. Well, the answer is Rhetta's disease. Rhetta's disease. Rhetta's disease can be caused by two mechanisms, either GIT infection, Shigella से, या it can be by sexual route. And whenever it may occur with GI2 route, it can occur in epidemic form. और जब भी ये सवाल आता है तो people get surprised, सवाल ही गलत है. Okay, lovely question. ये नीट एसएस का क्वेश्चन है. Next question, infusion of which antibiotic can lead to such reaction?
Vancomycin.
Vancomycin is the right answer. Okay, vancomycin infusion and idiopathic skin largely preventable by pre-treatment with antihistaminic and slower infusion rate. Next question for same team, in HIV, which enzyme needed for synthesis of pro-viral DNA in the host cell? Quickly.
RNA polymerase.
RNA
Polymerase.
reverse transcriptase. The right answer is reverse transcriptase. Team 8, हाथ खड़ा करेंगे. Team 8, yeah. Dugout choice for anaerobic above the diaphragm. That means lung infection अगर हो, lung abscess हुआ हो. Anaerobic above the diaphragm.
Clindamycin.
Clindamycin is the right answer. Above the diaphragm, clinda, or below diaphragm is metronidazole. Okay. Well, एक और सवाल. Long-term side effect of metronidazole, typically CNS में. What is the CNS side effect of long-term use of metronidazole? Peripheral neuropathy is the right answer. Which antibacterial, antibiotic to be more precise, can cause prolonged QT interval?
Fluoroquinolones.
Say it again.
Fluoroquinolones. Azithromycin.
Yeah, fluoroquinolones and macrolides, erythromycin, the classical thing they talk about. Prolonged QT interval. एक और सवाल, again for the participant. Prolonged QT interval can lead to which type of arrhythmias? Torsive pointis is the classical question. Tell me in which electrolyte imbalance prolonged QT interval can occur? Hypokalemia
Potassium.
and hypocalcemia, hypomagnesemia, they all lead to prolonged QT interval. Which carbapenem is not effective against Pseudomonas? Yeah.
Ertapenem.
Answer is correct. Ertapenem is the one which is not effective against Pseudomonas. Team 9. Team 9? Yeah. How can you avoid galenocytopenia caused by administering sulfonamide?
Low dose.
Well, the right answer is prescribe leucocovorin is, if you give sulfide, this the way we can avoid. How do mycobacteria get resistant to INH?
CAT-G and INHA.
The answer is correct answer. Bacterial catalase peroxidase encoded by CAT-G is needed to convert INH to active form. INH resistance arises due to mutation in CAT-G, and that means it will not be converted into active form. Which electrolyte must be supplemented with amphotericin?
Potassium.
Potassium, the right answer. Potassium and magnesium, but anyway, potassium, the right answer. The very important cause of hypokalemia. Now tell me, when we are treating any case of anemia, in which condition hypokalemia occurs? सवाल ध्यान से सुनना. You are treating a case of anemia and you start getting hypokalemia. वो कौन सा anemia है? Little louder.
B12 deficiency.
Answer is B12. Pernicious anemia के अंदर when you are treating, we get hypokalemia. Okay, let me give you a little bit more information. अगर आप हैरिसन 18, 19, 20, 21 ये 4 एडिशन पढ़ेंगे, उन सभी में लिस्ट बनी है हाइपोकेलीमिया का कॉजेज का, बट डिस्क्रिप्शन में कुछ नहीं है. बट इफ यू रीड 15, 16, 17 एडिशन, उसमें डिस्क्रिप्शन में ये लिखा है कि यू ट्रीट ए केस ऑफ B12 डेफिशिएंसी, पनीशियस एनीमिया विद B12 लीड टू हाइपोकेलीमिया, और कुछ नहीं है. बट इफ यू रीड 10, 11, 12, 13 एडिशन, इसमें सेम टेबल है, लेकिन उसमें लिखा है व्हेन वी ट्रीट ए केस ऑफ pernicious anemia with B12 folic acid, it lead to hypokalemia. The reason giving is when we give B12, large number of cells are being formed, and potassium being an intracellular ion, it lead to hypokalemia. फिर आगे लिखता है कि why this does not happen in when we treat other deficient anemia like iron, reason not known. ये 10, 11, 12 और 13 में लिखा हुआ है. Anyway, as of now, the beautiful question is hypokalemia. एक और सवाल. Anybody will answer this question, only question for the participant. Which other hematological problem occurs when we treat B12 in pernicious anemia? Cup of coffee is a treat. और क्या problem होती है? Raise the hand. I should know who is answering. Thrombocytosis. The platelet count may go as high as 8 to 9 lakhs. You may even have to give low dose aspirin to prevent clot formation. Team 10. This is a very easy question. Nosocomial pneumonia when occurs after admission and discharge. ये गलती नहीं करनी है. I think it's a bit easy question. Yes, quickly. Come on.
48 hours of admission. 7 days of discharge.
No. 48 तो सब पता होता है. दिक्कत 90 days में आती है. It's 90 days.
Half.
5 mark नहीं सर, PG लेवल पे चलो ठीक है, हमारे 5 marks एग्री, जो जज कहे वो बात सही है, वी ऑनर. 90 days ये लगभग सब, दिस शुड नॉट बी, ये गलती नहीं करनी है. नोजोकोमियल निमोनिया और कॉमनेस कॉज ऑफ नोजोकोमियल, अगेन क्वेश्चन फॉर द पार्टिसिपेंट, कॉमनेस कॉज ऑफ नोजोकोमियल निमोनिया इज ग्राम नेगेटिव बेसिलाई. पर जो लोग यूएसए का एग्जाम लिख रहे हैं वहाँ पे स्टेफाइलोकोकस है. हमारे यहाँ इफ यू रीड हैरिसन उसमें लिखा हुआ है कॉमनेस कॉज ऑफ नोजोकोमियल निमोनिया इन यूएसए इज स्टेफाइलोकोकस, लेकिन हमारे यहाँ अभी भी इट इज ग्राम नेगेटिव बेसिलाई. क्वेश्चन 2 which again I think bit easy. What
Neisseria meningitis.
Meningococcal. Meningococcal is the right answer. And suppose a patient with meningitis come to you, देख के कैसे पता लगाओगे कि ये meningococcal है? देख के ही. रैश 85 में दिल्ली में बहुत तगड़ा एपिडेमिक हुआ था. Okay, lot of cases with rash. And next question, which problem can occur in a newborn if oral erythromycin is given? Quickly.
Hypertrophic pyloric stenosis.
Answer is correct answer. It is a hypertrophic pyloric stenosis. Well, मान लो एक adult patient आता है, उसको pyloric stenosis हुआ पड़ा है due to peptic ulcer. History में क्या चीज़ मिलेगी? By which you can say this is pyloric stenosis. History. Answer is, if the vomitus contain food eaten many hours before, is a diagnostic of gastric outlet obstruction.
Sir, we have 3 minutes left, sir.
Huh?
3 minutes. 3 minutes are left.
Oh yes, I'll finish last time. तभी I'm keeping watch. हाँ, team 11. In which infective condition we can see coma vigil? Team 11.
Enteric fever.
Huh? Enteric fever is the right answer. Coma vigil क्या होता है? Neuropsychiatric symptom, muttering, with picking of the bedclothes is the coma vigil in enteric fever. Which organism can cause cat scratch disease?
Bartonella.
Answer is Bartonella is the answer, is correct answer. Extra learning point, result from bite of a cat caused by Bartonella. The last question, last team, which is your diagnosis? Quickly. No erysipelas. Okay. Erysipelas जो पैरों में होती है. Well, is both cheeks and bridge of the nose is the typical finding. Now, question for the audience. Last question है और हमने commonest cause of epidemic of hepatitis in India. The answer, yeah, quickly. Answer is hepatitis A. कितने A वाले कितने लोग? Only participant के लिए A वाले कितने हैं? B वाले? C, D, E. The right answer is E. Commonest cause of epidemic E है, लेकिन सवाल हो इन बच्चों में तो A आंसर है, तो दोनों फर्क है. Well, this is all what I have for you, and we have started late, but as I promised, finish in time. So इसके बाद we announce for the prizes also.
Good morning. All teams participated well, but team 1 secured 50 out of 50, and team 2 also secured 50 out of 50. Team 5 secured 40 out of 50, and team 10 45 out of 50, and team 11 40 out of 50. So we have some tiebreaker questions to make it first, second, third prize.
चलो वेल कौन सी टीमें हैं? T1 एंड 1 कौन से हैं? एंड 2. चलो कर्व 65 के अंदर टीम 1 के लिए कर्व 65 में पेशेंट को उसका यूरिया 28 मिलीग्राम है, तो कितने मिलीमोल होगा? टीम 2 4. हाँ जी, आपका क्या आंसर है? 10 is the right answer. Millimole को you convert by multiplying by 2.8 the right answer. So we got a winning team. Thank you very much. I hope you all enjoyed.
So we'll have the quiz participation prizes. We'll announce later on because we are running short of time.
So first prize goes to Team 2 LHMC. Second prize Team 1 UCMS. And Team 10 AIMS Delhi. Prize 3 Team 10 AIMS Delhi.
So thank you very much, and stay back because we have a very exciting session which is going on. We'll declare the timings of the prizes for first, second, third, definitely, but all the teams will get the constitutional prizes and certificates also. So stay back for learning, and we'll have a e-poster presentation. We'll start at around 11:15 in Hall B. So I request Dr. Swati for the next proceeding. Dr. Swati, please come for the next proceedings.
I request Dr. Mukesh Bhatia and the judges to kindly proceed to the felicitation desk for felicitations. I request Dr. Lalit to felicitate the judges and the quiz master. Good morning, everyone. A very warm welcome to the midterm conference of East Delhi Physician Association. So as you all are aware, the theme of our conference this year is infectious disease update. So we have carefully chosen all these topics in view of recent emerging infections. I hope you all will have a great academic feast. Now I will request our organizing chairman, Dr. RPS Makkad, to give his welcome address.
All right, good morning, everyone. After that exciting quiz competition, I think we are ready for the scientific sessions to get started. So welcome to this conference on infectious diseases. I think, as Dr. Swati said, we chose this topic very carefully, of course, going back 3 years back when we had the COVID epidemic. And we thought maybe infectious disease is one of the very important topics that we should be taking up in this conference. And of course, infection being one of the commonest conditions that we treat as the physicians in our practice. I am Dr. RPS Makkad. I was given the opportunity and privilege to be the organizing chairman by the EDPA committee. So I'm thankful to the EDPA Executive Committee for this honor. I'm delighted to have you all for this conference to discuss the latest developments in the field of infectious diseases. Of course, we all know that infectious diseases is a major global health concern, not just in the western part, but of course in India we have huge number of infections that cause a lot of concern to the physician community. And it's very essential that we as physicians stay at the top of knowing what the infections are, what the patterns are, and how we need to manage these infections in our clinical practice. And COVID gave us the right platform to really be on the top of this subject. And of course, this conference, I see this conference as an opportunity for us to be coming together, sharing our knowledge. We have a host of experts who will be giving us lectures and talks on infectious diseases, and we will hopefully at the end of the conference understand and address these challenges from the infectious diseases. Today, of course, we have, as I said, a number of experts who will be coming in pre-lunch, post-lunch, and then, of course, we have the evening sessions also. And they'll be presenting their expertise in the latest developments in the field of infectious diseases in their respective areas. We'll also be discussing some of the burning questions during our 2 panel discussions. So hopefully, those panel discussions will also be very fruitful for us, especially who are willing to learn in this field. I'm confident that this conference will be a great success. Thank you for being here, and we wish that you stay till the end of the conference because there's a lot coming. So thank you once again and welcome. And then I hand over to Dr. Paras.
Thank you, Ria Makkar, for those opening remarks, and welcome everybody on behalf of East Delhi Physician Association. Thank you so much for coming up so early in Sunday morning. Let me invite straight my panelists, Dr. Geeta, Dr. Vikas, Dr. Samantha, my chairperson, Dr. Lalit, Dr. Naresh Deng sir on stage, because we have to move according to timelines. So today, throughout the day, we human beings would be discussing what is the most dominant thing in the world today, that is microbes. All the sessions would be dedicated towards microbial dominance, and we as human beings have to achieve our power on them to control them. So, topic of our panel is acute febrile illness, a pragmatic approach to conundrum of numerous possibilities. This is a panel discussion with my esteemed faculty. So what do you see here? You see a human or you see a microbial environment. I think we human are so human that on 37 trillion cells, we invited 10 microbes, are hosting 10 microbes for each of 37 trillion cells. That means we are host to 400 trillion microbes in our body. So practically, we are 10% human only. We are 90% microbial. So that's the beauty of it. But these microbes are also paying back to us by giving us a healthy microbiota, which is the best known immune and the metabolic defense, which science is trying to understand further. Not only that we have microbes inside us, we have microbes around us, on our skin, and on our earth. How many? 5 nonillion, that is 10 raised to power 30. That means 5 million trillion. So that is the number, which is more than the number of galaxies. So they are there around us. They are trying to intrude us by our port of securities. Whenever our port controls gets weaker, they may ask for visa, they may not ask for visa, they may get a direct entry into you with or without your permission, right? So this is very important part, that you have to take a history. Whenever you are deciding what is the cause of fever, you have to take a history of port of entry. क्या खाया, क्या पिया, कहाँ गए, किससे मिले, किसने बाइट किया, किसने लिक किया, आपने किसको किस किया, where were the gaps in your urogenital port that some microbes entered into you. They might enter by contact, they might enter by vertical transmission. So we need to evaluate that history very carefully. Because once these microbes are inside, they initiate a chain reaction, which is chain of infection. So now goes a war between a microbe and the host immune system. So you have to take a history of how good or bad is the host immune system. Is the host having some immune deficiency disorder? Is he having a multiple comorbid pathologies or not? That is going to define who wins the war and what sign and symptoms you get out of that microbes. Because the war goes on for a defined period, which we call as incubation period. After that incubation period, we get our first presentation generally, which is fever. So we all know that fever is defined as elevated core body temperature, which is just beyond the normal range of 98.6 in the morning, around 6 a.m., and then it reaches a peak around 4 to 6 p.m. to 99.6 as per Harrison 99.8. So any fever which is beyond this would be labeled, any temperature which is beyond this would be labeled as fever, but there is a caveat. This has to happen with a thermostat which is in our hypothalamus. That temperature has to get elevated. If it is conjoined with elevation of our thermostat temperature, which is in hypothalamus, then only it is called as fever, because it is being mediated by prostaglandin E2 by various cytokines and endogenous pyrogens. If it is not linked to elevation of thermostat temperature, then we call it hyperthermia, because there is a difference between the two entities. In hyperthermia, body gets to a temperature which is beyond the hypothalamic thermostat level because of excess production of heat and because of lack of heat dissipation. The management of two is entirely different. In one will give prostaglandin inhibitors, that is NSAIDs, they would work. On the other will do cold sponges and cool fluids, right? Only they are going to work. NSAIDs are not going to work. So we busy clinicians are very quick to decide that our patient has fever, he has hyperpyrexia or hyperthermia. We differentiate the two. We go further and quickly with Nazifi, we decide that it is not because of non-infectious causes. So we know that our patient is having fever, but he is not having subarachnoid hemorrhage, he is not having intracerebral hemorrhage, he is not having myocardial infarction, he is not having pulmonary embolism, he is not having acute pancreatitis as a cause of fever, he is not having autoimmune disorders, rheumatological disorders, he is not having endocrine cause of fever in form of hyperthyroidism or maybe pheochromocytoma or adrenal insufficiency. We also know that it is not because of any neoplastic disorder or any other causes of non-infectious fever. So that's how we very quickly go to what we call as infectious fever. So once we say that it is infectious fever, now there are conundrum of possibilities. So what decides what is there? So we need to quickly evaluate what is the antecedent history, epidemiology, what is the exposure of the person, what is the incubation period, and what are the host factor habits. That only is going to define what kind of fever we are having. But most important thing is what? Most important thing is that you need to know what is in air. कि भाई आजकल क्या चल रहा है? मलेरिया चल रहा है, डेंगू चल रहा है, स्क्रब चल रहा है, H1N1 चल रहा है. And who tells you this? These esteemed panelists. You need a academician par excellence like Dr. Dang and Dr. Lalit. You need somebody in pathology and microbiology of the level of Dr. Geeta and Dr. Vishal. You need somebody in radiology like Dr. Samantha, who is going to tell you where these microbes are hiding and sitting. So these are the people who are going to tell whether it is virus or it is bacteria or it is a protozoan. So let's ask our esteemed panels that how do they go about the pragmatic approach towards diagnosing fever. So we know Dr. Dang very well. He has a busy OPD, he is a busy practitioner. So our question to Dr. Dang is that how in a set of 5 or 6 patients coming to your OPD with chills and rigor, myalgia, back pain, how quickly you are able to decide whether it is some specified cause of fever or whether it is acute undifferentiated fever or it is a viral fever. Because we know that you are so good that you hold antibiotics till the last stage and you do not prescribe them so easily. That means you have confidence that it is a viral fever. How do you achieve that confidence and how long are you able to hold those antibiotics?
So our examination starts moment patient is walking into the clinic. You see how the patient is walking, whether someone is helping him into the clinic, whether he's falling around and someone is getting him, or he's being brought on a wheelchair, is very important. If a patient is sick, then one thing is that you have to consider admission. Now, coming to the question of RS, if a patient has simple symptoms like fever, cough, running nose, you will think of simple viral infections which happen day to day. But keep in mind that COVID and H1N1 can also present similarly. So you have to keep a watch and look for SpO2. But these are the patients for first 3, 4, 5 days, you will not do too much investigation. Another set of patient comes who have fever, but who do not have any running nose, any itchy throat, etc., etc. Someone having headache, eye pain, severe body aches. If the season is right, you could consider dengue, do NS1 antigen. You'll probably pick it up. Similarly, malaria is something that can happen anytime in India in this tropical weather. And malaria antigen and malarial parasite also should be done in first 3, 4 days. I mean, dengue, malaria, you should have picked up in first 3, 4 days. Coryza, you should know what in first 3, 4 days. Another mistake that people do is they do a blood test, they find typhoid dot or Vidal test positive, put him on antibiotic. Irrespective of the fever pattern, I've seen people who don't have fever, even they are on antibiotics. And people who have fever and first 4, 5 days only Vidal test positive dekha or antibiotic shuru kar diya. Please don't do that. To my mind, single most important investigation that you need to do is blood culture. I'm not saying don't do typhoid dot, etc. But blood culture, if you have grown salmonella typhi over the next few days, you know that you are dealing with typhoid. And in case you don't do that, you start antibiotic, then you've done a great disservice to the patient, as well as if patient goes to another physician, it is a disservice to that physician also. He'll have to stop the antibiotic for 48 hours and reinvestigate.
So, thank you, Dr. Dang. I think this is the time you get jittery when the patient's fever is not subsiding. There comes the role of our pathologist and microbiologist. So we'll request how Dr. Geeta can help with ordering the first set of investigation, whether it is CBC or CRP or ProCal. How does they figure in a cost-restrained situation and which is not life-threatening versus a life-threatening situation when the cost of investigation does not matter?
Yeah, so CBC may seem to be a very, very simple test, but it gives a lot of information. Especially it's, if it's done with peripheral smear, that is a recommendation. So if, that viral, any dengue fevers, you'll, even malaria, may have, leukopenia with lymphocytosis. And thrombocytopenia, of course, follows. It is very, why I said PS is because, it will, the pathologist may say activated lymphocytes. It reaffirms that you are dealing with this situation. And of course, when there are bacterial infections, it's important, other than neutrophilic leukocytosis, it's also important to thrombocytosis and toxic change and mild shift of, neutrophils to the left. That gives great information that, you're dealing with a bacterial infection and it's worsening, it may worsen. So the other two important commonly done tests are CRP and procalcitonin. So CRP and procalcitonin, how we, little differentiate is that CRP, there's not, if you come across the literature, different literature says different cutoff values. So generally, the considered is accepted value is more than 20. So if more than 20 value is there, so you think that you're dealing with bacterial infections. And so the other thing is procalcitonin is very important. So procalcitonin, why, if you compare PCT and CRP, why PCT proves to be a better marker is because PCT starts rising within 4 hours of your infection, whereas CRP takes longer, 12 to 24 hours. and peaks at 6 hours, PCT peaks at 6 hours, whereas CRP may take 20 to 72 hours. So that becomes very important. And PCT starts coming down in 2 to 3 days, whereas CRP may take longer. So that is why procalcitonin becomes a superior diagnostic as well as prognostic marker. So, but it is important to see that, you know, if the cutoff is, here the cutoff is not a problem, it is well accepted. 0.05 is still the normal range. So more than 0.1, but bacterial infection, maybe any inflammation, but when you were talking about more than 0.25 or 5, you're dealing with bacterial infection most of the times. Of course, as it increases accordingly.
So very important take-home message that once CRP is more than 20, you are likely that you might be dealing with some bacterial infection, less than 10, maybe some viral illness. There are caveats in both the situations, which we need to remember. Generally, when we have abscesses, the CRP is going beyond 50. Typhoid average CRP is somewhere around 40 to 80. If you have deep-seated abscesses, the CRP is hovering around 150, 200, maybe 400 also. If CRP is less than 10, we can probably lie low and not prescribe antibiotics, but there are caveats to both. You have to analyze the whole patient, not just the CRP. Then, so comes the procalcitonin is a very good marker to escalate your antibiotics and de-escalation regimens, which we'll learn as more lectures come on further. So, now we are advancing to, there are situations when we can diagnose fever right on day 1 by use of certain new age tools that we have, and there are situations when we use antigen tests or antibody tests without knowing their timelines and the window periods. So Dr. Vishal, how do you advise on these?
Yeah, this is the crux of the situation where the clinician can use the information given by the laboratory. I'll just enumerate them one by one. Let's go with enteric fever first. So this test should be done post 5 days, as sir has already mentioned. If you do it before 5 days, you get a positive, that is a IgM positive, which can be, IgM antibodies can be positive till 6 months post-infection, post-resolution of the illness. So after 5 days, if you get a positive, you are likely to be seeing a current infection. But in our experience, typhoid dot is better because a lot of times our technical staff faces difficulties while analyzing a Vidal test. I'll give you one example. One of my colleagues' daughter could not be diagnosed on Vidal. When I went there myself on the desk, there was slight roughening on the slide, which the technical staff would not give. But when I put typhoid dot, the clear line was there. So we need to have an understanding that the way you have diagnostic dilemmas, the laboratory will have the same. So a test which is not subjective is always more advisable. On the same line, if you go with malaria antigen, yes, peripheral smear is the gold standard. If you want to see the malarial parasitic load, yes, it is the test of choice. But for initial diagnosis, I would also prefer malaria antigen. But the only caveat here is that do not use this test for prognostic purposes, because whether you are using an HRP-based test or an enzyme-based test, both these tests will remain positive post-resolution. Obviously, when you are going for an antigen-based test, it will remain for a longer time. Once as Dr.
What is your take?
Yeah.
Is there any specific test these days which is new age, which can diagnose anything on day 1? What is that? Yeah. Is it costly? Is it pricey? Yeah. What are those situations in which we should order that?
So I'll come to that. Let me complete dengue. Once you are in dengue, my advice will be go for all 3 NS1, IgM, IgG, reason being that each one will have its pitfall. If you're talking about a secondary dengue case, NS1 may not be rising. So that is an important miss here if you're only banking on NS1 in secondary dengue, which is obviously more important. When we talk about secondary dengue, IgG is the one which will rise on the second day, unlike usual pattern of IgG rising, and IgM may not rise. And there are problems with chikungunya and leptospira. Let me now address what sir is asking, that what are the new age tests. First being the multiplex PCR. You will have patients who will want to be diagnosed within 5 days, within 3 days of illness because of their certain bindings of job or traveling or exams and things. Here you can offer the patient multiplex PCR, which is a blood-based test which can diagnose an acute undifferentiated febrile illness. The target is AUFI within 7 days based on multiplex PCR, giving you a diagnosis of 8 different kind of agents, including enteric and including the rarest ones of Zika virus. Lastly is the multiplex PCR for IDN sensitivity, wherein you can directly order on a sample, be it CSF, or you can add on to a culture positive case where you'll get the positivity for different types of antimicrobial resistance genes till, KPCs, carbaphenamases, and all those latest resistance mechanisms can be diagnosed within 1 hour of adding the test.
So you shell out maybe 15,000, 20,000 rupees from your pocket on day one. If you are too pricey, VIP, you are a very high risk situation, and you want to kill the right microbe by right diagnosis. This is the new age test which we need to order. We have a full session on multiplex PCR. This we need to get acquainted with soon. So now, without a radiologist, we might miss so many infections, right? And radiologist is the right person to direct where the microbe is hiding, where is it creating the havoc, where is it creating the lesion. So Samantha, what is your take quickly for we physicians that we should not miss ordering?
So when we get a patient in the radiology department, we only know history of maybe fever, some other history of abdominal pain, maybe loss of consciousness, whichever the microbe, the organ or the body part it's involving, we get a scan required for that region. Now let's divide it into systems. Suppose we are getting a case of CNS. It is a CT brain or an MR brain in a case of dengue. Then the radiologist role comes in whether there is hemorrhage, whether there are complications, whether there is encephalitis, in which the treatment management also changes, and there's an radiology as an adjunct to clinicians after their laboratory, microbiology, pathology. It's a multidisciplinary management when it comes to infection especially. Apart from that, X-ray and ultrasound have become so portable that now it is easy for accessibility, going to bedside and doing these investigations where the patient does not have to be shifted from the ICU if he's in a sick state. So again, point of care ultrasound comes as a very important aspect. Secondly, there's also further when clinicians are treating whether the endotracheal tube is in place, whether CVP is in place, which are very critical in those patients. Probably the lung consolidation is because of more insertion of ETT. So again, radiology plays a role as supporting with the ongoing treatment, whether it is being delivered quickly.
That's very great of you that without radiologist, you cannot even diagnose a effusion, a pleuritis, a tuberculosis, abscess. They are the first one to pinpoint where you missing the thing.
And
so thank you, Samantha, for that. And we all need to understand that these investigations might look costlier, but we heard these sayings all through and through. Time is money, honey. Diagnose things in time so that you can safeguard your health, which is your wealth. We say cost benefit analysis. We see day in day out कि यार आज छोड़ देता हूँ culture नहीं भेजता, आज छोड़ देता हूँ multiplex PCR नहीं भेजता. Within 24 hours, your patient becomes sick and he's in ICU. You are trying to save 15,000 bucks, 20,000 bucks. Now this guy goes in ICU, loses his life. You were thinking about saving 20,000 bucks, and you wanted to give all absurd antimicrobials which were not required to the patient. So I think the time has come that we save our microbiota, we save our health. We save our money, we save our wealth. So your microbiota is your wealth. So invest your money, hard-earned money, appropriately. And I'll request Dr. Lalit to sum up, what is the best take-home that you can give?
Well, the best take-home for all physicians today is as soon as the patient enters you, the clinical aspect is most important. Clinical aspect and how you examine the patient. That is most important. Will give you a guideline where you have to take your investigation. Treat the patient in right direction. Investigate in right direction, because if you do all the tests haphazardly, it's not going to lead to any situation solution. So according to clinical and physical examination, do the right test and treat the patient as early as possible. So all these things, clinical, investigation and treatment, all these things are very important for treatment of febrile patients.
So that's the best take home. Let's do the kill, but let's not overkill. We need to have a diagnostic and antibiotic stewardship, right diagnosis in right time, precise diagnosis, right dose, right duration. That is the theme of this conference. Let's learn that as the lectures roll on. Thank you very much for your patient listening. So in the interest of time, we'll take questions when we have question answer rapid fire. And I'll request my panelists to come for a photograph session. And over to organizers.
Thank you, sir. That was a wonderful session. Now I request Dr. Harshita Tyagi to come over to the stage to start with the next session, which is on tropical fever syndrome.
Good morning, everyone. A very warm welcome to August gathering of savants here to dispel the spell of infections shrouding over our profession and surroundings. Fever, if no doubt, is bread and butter of physician. It is also our profession's graveyard. To discuss tropical fevers, now I call upon our esteemed chairman, Dr. Ashok Grover, Dr. N.K. Govil, Dr. A.K. Shukla, and Dr. Bharat Bhushan. Kindly come on the dais, please. Respected Dr. Anupam, good morning to you. Can you kindly ascend dais to guide us in situations, unusual discernments, and judgments in dealing with such common but many a times deadly fevers? Thank you.
Do I have the permission to start? Well, thank you, chairpersons. Thank you, organizers. It is a difficult task to speak after a enlightening and interesting quiz and a panel that was conducted by Dr. Paras. And the time and the topic that have been given to me are a mismatch. And ideally, I should have been given the first choice as an opening batsman rather than Dr. Paras, because they have covered most of what I would have liked to cover. But anyhow, I will try to cover the things in the right earnest as a clinician. So I will be dealing with malaria, dengue, typhoid and beyond. So that beyond is interesting, but when we talk of fevers, yes, we talk in tropical countries, it is not only infections, but non-infectious diseases also, which are very important. And when we deal with any fever, as was being talked in the first session, it is acute undifferentiated fever that we are most concerned about. And what we discuss about, we search for patterns of fevers and the associated symptoms. When we have associated symptoms, yes, it is easy to localize. And in examination, we search for a potential diagnostic clue. So that could be in any way, any of the examination findings. And this is just a summary slide, which I would say as a clinician. And it is important for us to realize, if you are a good clinician and you rely upon clinical skills, then it is important to understand these are the features which will help you distinguish between malaria, dengue, typhoid. So in malaria, you get a firm spleen, while in enteric, you get a soft spleen. And dengue does not have clinically splenomegaly, although radiologists may pick up slight splenomegaly, but yes, it is not a clinically palpable spleen in dengue. Lymphadenopathy, I have specifically mentioned, it is not present in either of the three, but I will come down to that later on. Rash, again, malaria, it is highly unlikely unless until the patient is having DIC or thrombocytopenia. But yes, you have a rash in dengue most of the times, whether it is evanescent, whether it is thrombocytopenic. And in typhoid, yes, you have a rash, but in our country, we do not find easily the rose spots which are there. Jaundice could be present in any condition, but yes, unlikely in dengue. And even in malaria and enteric, it is usually a transaminitis and mild jaundice may be present. Hemorrhage, yes, I have put a star here because malaria is not associated with hemorrhage unless until you have DIC again or thrombocytopenia, severe thrombocytopenia. Dengue, yes, characteristic. Enteric can have any manifestation, but unlikely in today's era where you have a patients who take antibiotics on the first day, as was being discussed. So typhoid, we have partially treated cases. Usually we do not get into that complication of hemorrhage or perforation. Neurological signs, yes, maybe in any of the three, malaria, dengue, typhoid. If we deal cerebral malaria, definitely you will have meningism or neurological signs. Dengue and encephalitis we have seen, very common. and typhoid also you can have enteric encephalopathy, but yes, usually in the second week or fag end of first week. Joint involvement, arthralgias, I have mentioned caution in typhoid because yes, you can get monoarticular arthritis in typhoid, and earlier times you used to get osteomyelitis also. So we should not forget, if we use antibiotics haywire and if we develop into resistance, then we will have again this complication of osteomyelitis sooner or later. Respiratory, yes, ARDS, AKI in malaria. Dengue, yes, AKI is common. Typhoid, you can have all the three. Respiratory involvement, enteric bronchitis, you can have ARDS, you can have myocarditis. We have that relative bradycardia, which is part of sinus node depression in typhoid. Also renal involvement, very common. So this is clinical. When you have a patient, if you have continuous fever, yes, it is typhoid. But because the pattern of fever is disturbed because of taking of NSAIDs or antipyretics, we usually get an intermittent fever or a remittent fever, and that is why there is difficulty in differentiating. Coming to enteric fever briefly, so this is 4.5 million cases estimated every year, and it occurs throughout India. The clinical profile I have discussed, but yes, fever, abdominal pain and diarrhea, vomiting may be there, which is common, and there is a relation which I talked fortnight back also, cholecystitis, encephalopathy, GI bleeding, hepatitis. They all occur in patients who come late, more commonly as compared to patients who come early. So this is DDA, that is time duration before admission. If it is more than 10 days, you have a whole lot of complications in enteric as compared to patients who come early or are started on antibiotics early. This is a whole lot of manifestations which you can see in enteric fever, which because of early use of antibiotics we have averted. But those who come late, you can have anything and everything virtually under the sky. Diagnostic considerations, I will not go into detail, they have already been discussed, but these are the things we rely. When we do not come to a conclusion, we have to go to blood culture and bone marrow culture if we are not able to diagnose or if the patient has already received antibiotics. Ceftriaxone has stood the test of time and still holds true, and it is very effective. Oral cefixime is also effective. Remember, no magical response with enteric fever. You start antibiotics, don't expect that fever will come down within a couple of days. Fever response coming before third day is unlikely to be enteric fever. It must have been some viral fever. But yes, remember, even if you do not give antibiotics for a sufficient duration, 7 to 14 days, 10% of the patients will continue to discharge and they will become carriers. And that is the problem, they will spread the disease also. Don't undertreat. I agree with Dr. Paras, don't go for the overkill, but you have to have overkill for typhoid, it is important. Azithromycin is effective. So remember, the dose is 20 milligram per kilogram per day for 5 days. If you give lesser dose, you have to prolong for 7 days. And this is very important, nutrition during convalescence is very, very important. Enteric fever is a highly catabolic state. Even without complications, the fever drains the patient down. If you want your patient to recover early, always cater to the nutrition of the patient. The second is malaria that I have to deal with. So I have especially mentioned this. This is the advantage now over last 2 decades or quarter of a century. The cases of malaria have become too less. They are still high, 5 million cases. I showed you 4.5 million cases per year for typhoid. So now malaria and typhoid are roughly equal, but yes, enteric occurs over a longer duration in the year as compared to malaria, which is more sporadic related to the monsoons. The treatment, ACT is what we are using, although in Delhi we can still use chloroquine. I always go by that. But yes, most of our patients come from UP, especially in the eastern part where we are here. And UP is chloroquine resistant belt partly. So that is why you may be justified in treating with artemisinin based combination therapies. So you have artemether plus lumefantrine, 1 tablet twice a day for 3 days, or you have artesunate for patients who are comatose or are not able to take orally. So you give 2.4 milligram per kilogram, 0, 12, 24, till the patient, then once a day, till the patient is not able to take orally. And once the patient starts taking orally, give the oral tablet, artemether plus sulfadoxine plus pyrimethamine for a week, maximum a week, not more than that. If the patient is not responding, then the patient will not respond by giving more duration of antimicrobials. Either the patient has irreversible damage or the diagnosis is wrong. Always remember this, don't just keep on giving antibiotics. Quinine was the gold standard, and those of you who are senior persons here and who have used quinine understand that one dose of quinine and the patient is up in about 4 hours or 5 hours. So that is the magic with quinine, and that is why it is being preserved. 20 milligram per kilogram stat dose followed by 10 milligram per kg 8 hourly. The problem is hypoglycemia. But yes, remember about severe malaria. If you have severe malaria, go for the IV antibiotics, admit the patient and treat. This is important for all of us to realize. This is just a depiction. Although the cases have reduced, but the problem is that a fair share is with P. falciparum. So 50 or 49% of the total cases in the country are falciparum now, as compared to earlier where it was hardly 10-12%. But yes, still the decline in cases is there, so that is important. And this is also important. This is just a diagnostic slide. For overlap, you may just see microscopy, RDT, rapid diagnostic tests, and PCR. So that is the advantage with PCR. When we are talking of eradicating malaria, we don't want to miss this 3% also. 3% accounts to 10% more cases being diagnosed. So if we have the facility of PCR, as Dr. Par is saying, we are having multiplex PCR session also. So yes, that will help us in arriving at a diagnosis and not missing diagnosis. That is very good, because at least you will be able to diagnose. Dengue, I will not dwell too much in detail because we all understand. So bleeding could be a number of causes. I already discussed a couple. And thrombocytopenia also could be a number of causes. One is bone marrow suppression, but it is important to realize bone marrow suppression will be transient. You don't have to worry about it. That is why we usually do not worry about thrombocytopenia and dengue. But yes, if there is antiplatelet antibodies, that is why people have used steroids, and some may be justified. But this is not a recommended test, and we don't go for it. Most of the cases will have bone marrow suppression in early stage, where you have to just wait and watch. But yes, if the patient has DIC, then you have to be careful and manage according to DIC. Warning signs of dengue fever, very important. This is what is very important for all of us to remember, because these are the patients who cannot be and should not be sent home. Because if you send these patients home, they may not return back, and they may come in a stage of irreversible shock where it will be very, very difficult to manage. So this is very important. This is just the guideline, what you need to do. I am not going into details because I understand that most of you are aware about it. So patients, the aim in dengue is manage fever, prevent toxemia, prevent dehydration, prevent spread of dengue in the house and vicinity also. Very important. And watch for warning signs. These are just some of them which I already mentioned in the previous slide. And you don't need to concentrate upon this. You don't need to cram upon this also. Remember, when you start the patient on IV fluids, that means that patient is either having dengue fever with comorbidities, or the patient is having dengue fever with warning signs. Those are the patients who are supposed to be admitted, and those who you have to start with on IV fluids. So isotonic saline or Ringer's lactate in these patients, and start at 5 ml per hour. Give for 1 to 2 hours, reduce by 1 to 2 ml. So the next stage, if the patient's hematocrit falls, then it is you reduce to 2 to 3 ml per hour, and then again you can reduce a fair bit. So that is the assessment every 2 to 4 hours you require. And if the patient's hematocrit is still rising, then you double the rate, increase from 5 ml per kilogram per hour to 10 ml per hour. And if the patient is going into compensated shock or uncompensated shock, then you will need to increase to further 10 to 20 ml per hour. So this is a fair algorithm. You don't need to cram up anything. Don't go into the vicinities. If the patient's hematocrit, so the main important thing in dengue management is hematocrit and not platelet. One should remember this. Platelet counts less than 10,000 also do not bleed spontaneously. That is a theoretical thing. You will have 1 in a million cases. So you need to bother about the remaining 9,99,000 rather than bothering about that 1 millionth case. Yes, I understand that will take you to the court, but yes, be careful. So these I have covered in the last 5-7 minutes. I will cover what is beyond. Now malaria, typhoid, dengue, I can go through in 10 minutes, 12 minutes and still enjoy sitting there because I know all of you are well versed. But the problem comes what is beyond, because we do not know multiplex PCR. If you go through those tests which are written, most are viral. Even if you diagnose, they do not help. You have to sit idle and you have to wait and watch or give conservative management only. What is reversible is only typhoid and malaria. So that is the problem. So diagnostic beyond is not only difficult but also difficult in management. So that is the problem. And this I always keep this slide because I was surprised when I saw this slide. This is from CDC, this is not my slide. So these are different stages of, you can see a papule, vesic pustule, umbilicate pustule, a sloughed out ulcer. So all stages of lesion. We usually talk of chickenpox like this. But when I saw this, this was monkeypox. So all stages can be there in a patient at the same time. So that is the problem. This is what is beyond us, diseases which we do not know or which come less often. We know these are the areas where we will have now monsoons, flooding across Yamuna, you will have typhoid, malaria, dengue, everything will be there. We know these seasons. These diseases we do not know, and that is the problem that we have at hand. And with global climate change and global warming, these are the problems which will come in and knock every year or maybe twice a year or some years. So that is the problem with us. I am not going to details of this, but yes, this is important. So when you have an atypical sign or a less common sign, think of an unusual manifestation or think of a new. So this is problem. If you have lymphadenopathy in a patient who has fever and some type of rash, monkeypox is a distinct possibility. So that is why I showed lymphadenopathy is not seen in malaria, typhoid or dengue, but yes, monkeypox, this is very important. Regional or generalized is very important. The other thing is pattern of rash. You do not have centrifugal rash in any other disease excepting smallpox, and now monkeypox. Chickenpox is from the herpes viruses, so chickenpox is centripetal, it is not centrifugal. Another thing is lesions on palms and soles. So you have lesions on palms and soles in monkeypox, you have in secondary syphilis. And what epidemics you have or outbreaks you have of hand, foot and mouth disease. So temporality is important. I am not going to details of this, but yes, you should remember this. This was what was taught to us in pediatrics and holds true today also for us because we have to identify new diseases. So there are a whole lot of mnemonics. You should remember this. So typhoid, obviously 7th day, you don't need rash. You have other manifestations also. But yes, earlier in the disease, it is important for all of us to know this mnemonic and identify. What to seek in examination? So this I have already talked about. I am not going to details. But yes, this is important. Apart from what, when we talk of beyond, this is meningococcemia. This is herpes zoster. So they will all come to us. This is scrub typhus. We had this patient 7 years back, and a couple of weeks back, last time when he had taken lecture, the next day only, I got a photo of a rash from West Delhi, and that was Ishar of scrub typhus. So it is available, present in the community and coming to us also. And this is measles, common but difficult to distinguish at times with drug rash. At times we do have fever with jaundice. I will not go into these pre-hepatic or post-hepatic, but yes, this is very important. We do get intermittently cases of leptospirosis, hepatotropic viruses in this season, very important. Hepatitis A, hepatitis E, enteric we have discussed, malaria, liver abscess, the radiology part was covered earlier. And at times you can have yellow fever imported. We had Lady Harding residents are there. We have a quarantine center for yellow fever when the Sudanese, Indian nationals at Sudan were evacuated and quarantined in our country. Scrub typhus, I already said. This is the last part, fever with neurological syndromes. Very common, very important. And apart from this, don't forget tuberculosis. Acute febrile illnesses with meningitis, don't forget tuberculosis. The others I had discussed, you can have a whole lot. And these are diseases which are near eradication, but don't miss to identify them. So this is tetanus, trismus you can see, this is polio, and sorry, this is Japanese encephalitis. So these are diseases which have reduced, which are going to be eradicated. This trismus and opisthotonus you can see. So they are all diseases which are near eradication, but very important to identify in our scenario. If we forget them, we will land to trouble. And this is tuberculosis, which can mimic the greatest mimics. So you can have florid environment, you can have an effusion, you can have miliary tuberculosis. So go beyond also. There is no limit to beyond. The universe is vast and infinite. But yes, this is the last part. So non-infective causes or atypical infections. So very important, this need to be taken into account when you are dealing with an acute febrile or tropical fever syndromes. Vasculitic rash, whether it is tuberculosis or it is connective tissue or it is a autoimmune disease, ANCA-associated vasculitis, important to identify. Not to forget diseases, especially and heat-related disorders in the summers. These are non-infective causes. Tropical fever, always consider heat hyperpyrexia and heat stroke in a country like ours where you have temperatures crossing 45 degrees centigrade and heat waves. Well, thank you, and all of you are requested or invited for EPICON 2024 at Delhi. I think I have finished in time. We have 30 seconds. Over to the chairs.
Thank you, sir, for a wonderful lecture. You cover almost all aspects of fever, and apart from the topic concerned, tropical fever syndrome also. Definitely, we can invite one question for sir if anyone have.
It's difficult to answer your questions, but still I will try. So that part I intentionally didn't cover. You have vaccines for all. Enteric fever, you have a new vaccine. Conjugate vaccine is available. We should take it. It is a longer vaccine than 3 yearly vaccine or capsules which were available. 3 days you take 035. So that enteric fever vaccine is available. Malaria vaccine is in the pipeline. We may have it, not right now available. And dengue vaccine, the initial one had a problem with our country. But yes, the improvised version may come in a couple of years. Yes, sir.
I want to know, and in fact regularly I am seeing Vidal positive for months together being treated as a typhoid fever. I want to ask you for how long the Vidal test is positive, once it is positive, and do we consider any value to Vidal positive test?
This is the problem when you finish the lecture early. The panel discussion exceeded, so that this question should have been answered by the panel. But anyhow, I will try to answer it. Antibodies once formed, they do not wane easily. So Vidal can continue to be positive for at least 6 months, but maybe years also at times. That depends upon your own body, how much time they are retaining. And if you have some subclinical infections, the antibodies may not disappear. So Vidal for the first infection is very good, unless until you document that the Vidal has gone down and the antibodies are not tested. Doing it again may not be possible to make a diagnosis of enteric fever again.
Thank you.
So that you will have to realize, that is why RDTs are very important. IgM typhi dot is for all things antigen testing now is the standard which you have to follow.
I think we will have no more questions.
Booster for what disease? See, conjugate vaccine has come just now only, it is a couple of years only. And typhoid vaccine, conjugate vaccines don't need to be repeated. There is no booster is required.
So only one dose?
One dose. If at all it is required, it is past 65.
Thank you very much. We close this session now. Thank you, Dr. Prakash, for that wonderful explanation.
Thank you, sir, for the crisp session. Now I request all the faculty to join us at the felicitation desk. I request Dr. Anil Mota to felicitate all the chairpersons and speakers. Now I request Dr. Ruby to join us on the stage to start over with the next session.
Good afternoon. Rather, it's just morning. So good morning. Now we have a very important session on sexually transmitted infection, for which I would like to invite our chairs, Dr. Girdhar, Dr. Mukesh Girdhar. Sir is a very senior skin and VD specialist and practicing in East Delhi since I think more than 20 years. Dr. Tiwari. Dr. Tiwari is also a senior physician in East Delhi and he was serving to Lal Bahadur Shastri as well. Yeah, now he is retired, but he is still academically very strong person. Dr. Viresh Mehta. Dr. Viresh is also a very senior physician in East Delhi, practicing East Delhi. And Dr. Chakravarti. Dr. Chakravarti is a physician in Noida. Yes, sir, if I am correct. So he's a senior physician practicing in Noida. And we have our eminent speaker, Dr. Saurabh Jindal. So I will request the chairs to introduce, or I will. Dr. Saurabh Jindal is a senior PD specialist and practicing in East Delhi and Max Vaishali, and he is academically very strong. He is a teaching faculty to many NEET PG students. Yeah, so far I know, and he is very busy in teaching them. So I will request Dr. Saurabh Jindal, and we will have an interactive session, basically because sexually transmitted infections are, I mean, definitely there, but so far we are not having a much of outlook of taking the history of the sexual history. So we will listen Dr. Saurabh Jindal. Yeah.
Hello. Yeah, good morning to you all. So sexually transmitted disease, commonly we are finding they are coming to the skin specialist, they are also coming to the physicians as well. So I recently came across a patient who has applied for a Kuwaiti visa, and this patient came without any symptoms, just saying with one report that VDRL is positive. So how do we approach such patients? This patient, nothing is there, no clinical sign symptom, and he has been simply discarded because of VDRL positivity. So today, definitely we learned from Dr. Jindal what is exactly happening. How do we approach such patient as a physician? Over to you, sir.
Should I? All right. So good morning, everyone, and welcome to this session of STDs. Thank you for this honor, and I am very glad and excited to share something which I remember when we were MBBS, and now for people who are non-dermatology people, it's been quite a challenge to look at STDs and to look at what to do about it. We often get references from physicians for STDs and what to do about it. So what we'll talk today is not really a very theoretical stuff. That's not the intention for today. I'm not going to discuss the contents of a Thayer Martin medium, for example. That's not relevant. That makes it boring, and that doesn't give you a take home. So today what I want to do is really give you a take home rather than something which is theoretical, something that you can read in your books as well. So what we're going to do today is basically look at some the lecture actually is common practices, which means that something that you can do in your OPD as well, right? So we want to talk about that. The first thing that I really want all of us to know as physicians is most of our patients really believe that condoms actually are protective for STDs and really prevents all the STDs, so they think it's safe sex, but we don't think it's safe sex, we think it is safer sex. There's a word difference on that. Just the word letter R makes it a different, means what? There's so many people who come to us saying that we are responsible people and then we are using condoms, so I should not be getting STDs. Let me give an image. Basically, the secretion transfer STDs, the secretion transfer definitely go down with condom use, which means HIV, gonorrhea, chlamydia, trichomonas definitely have a much lower incidence when it comes to STDs. But when it comes to skin-to-skin transfer STDs, we have a massive gap in condom use. We do definitely get as much STDs, a little bit lesser, but still a lot, meaning warts, molluscum, syphilis, herpes. We see a lot more STDs now from this, because it's going to be a condom use is increasing, but then still you're going to get an STD thing. So I'll give you an example. For example, look at this. This is a very common thing. We see it a lot. We see a lot of these molluscum, it's called molluscum, these shiny papules coming on the genital area. We expect this person not to have used a condom. But look at the second image. This is something that we see so much. We see so much STDs at the base of the penis. You can see something on the thigh. And this fellow was so surprised when I told them that this is an STD. He said, no, I've used a condom. How can I get it? He said, no, the condom only prevents the front part. It doesn't prevent the back part. So he was so surprised. So we see so much STDs now on pubic areas, on the inner thigh or the root of the penis. So it's very important for us to make the patients aware this is not safe sex, it is safer sex. It's still going to give you STDs, and it's something that somehow gets missed. From a doctor's side, we need to tell them this. It's one of the most important things I want to start with. Now, how I'm going to discuss stuff is how to diagnose, investigation, but only if it is needed. We are not going into the theory part of it. We are not going to go into the biggest PCR things. We're going to talk about the daily life practices stuff and obviously treatment. So let's start with one of the commonest things that most of us see in the OPD, and that's herpes. Herpes is an incurable disease. That's why most of our OPD is going to be filled up with a herpes patient. How do we diagnose herpes? How do I diagnose herpes? Now, the first way to diagnose herpes is going to be multiple ulcers. That's how you diagnose herpes. The first thing you need to know is multiple ulcerations, usually very superficial ulceration. It's not very deep. It almost looks as if, जैसे patient बोलते हैं ना, कुछ छील दिया. A superficial skin has just come off. It's not a very deep ulceration. In fact, we call it an erosion. We don't even call it an ulcer. It's not a deep necrotic ulcer. It's a superficial lesion, and it's usually flat and superficial multiple. Some of them do report some vesicles before it, but most don't. Because most of them will say that we didn't notice the blister, so we may not see this. What we see is the superficial lesion. So how do we diagnose? What are the pointers for diagnosis of herpes? It has to be grouped. That's something that we see all the time. It has to be grouped, it has to be painful, it has to be multiple, and it has to be recurrent. The 4 ways to diagnose herpes. One of the easiest way to diagnose herpes for the physician is just look at these 4 pointers and we have our diagnosis. And we usually find some prodrome. They might say that there's some tingling happening there, and that tingle is basically how you say, okay, it's almost like an aura kind of a herpes. I know it's going to come, that kind of a thing is what patients would say. Oh, I've got this force, maybe I've got for one day I'm feeling something there, and that's usually a herpes thing. And we know that's going to usually have some kind of local lymph nodes. Some buboes on the inguinal area, that's something that we see as well. That's usually a very easy way to diagnose herpes in patients. How do I investigate? Do I investigate? Is the first point I want to understand. Now, usually I don't. It's difficult to get, it's best to do it clinically, okay? Investigation is a bit tougher. Usually it is not required, okay? We do have a ZANC, but usually in a physician's office, how many of us are doing ZANC? So let's not even bother too much about it. Now, what I really want to talk about is serology, which most physicians will ask for, and I'll tell you the caveats on that, which is a take-home thing again for us. There's just for the ZANC, which I'm just going to omit because not many of us are even doing it, so we'll just skip this slide completely. So let's talk about serology, which is something that most of us are getting into. Now, usually we want to do it for the first episode if you're confused about the diagnosis. We also want to do it for a recurrent situation because we know it's recurrent. The caution points for serology. The problem is most labs will do an HSV1 and HSV2 combined IgG, IgM titers. And if you see many reports, they'll say HSV1 and HSV2 IgG, IgM. The problem is that is not a good investigation because it doesn't differentiate between 1 and 2. It also does not differentiate between oral and genital. So an oral HSV1 can give you a titer positive for HSV2, and there's a lot of cross-reactivity. So what you want to ask for is something called a type-specific HSV2. You want to ask for that. It's only an HSV2 to IgG, IgM. That's a much superior test. Don't ask for a combined test. A lot of labs do that. A lot of patients which I have will automatically get that done from a lab because they have had a sexual exposure, they were unprotected, they wanted to know whether they got HSV, they go to the lab, get it done and get you the report. See, कि मुझे तो डर लग रहा था, I got it done, doctor, this is positive. But that may be HSV1, But that's basically come from a kissing behavior, where HSV1 came on the oral mucosa, and that gave you HSV2 positivity, and that is not something you want to do. IgM may take even till 10 days, and that's a problem. He's had a sexual exposure, he's got a HSV ulcer in 5 days, and his IgM is negative. So it may take till 10 days. So again, we want to know this. We may have to repeat this IgM after a week or so to really see if this was herpes or not. And the IgM will then go for about 7-10 days, then go away from there. Specificity about 100%, sensitivity about 79%, so not very sensitive. So you may miss them, false negative tests are there, and that's why we need to know this so clinical diagnosis, very vital. I thought I was getting 10 minutes, so there is a problem in the timer, sorry. Okay. So how do you interpret? Okay. IgM positive, IgG negative, this is called true primary. True primary means I have a sexual exposure, I get the disease, that's called true primary. I get the disease right there. If I have IgG positive and IgM positive, this is called non-primary first episode, which means that I would have got the sexual exposure, I would have got the herpes inside without an episode. And then I get an episode after 4 years when I have not had sexual exposure possibly, and this is IgG of the past and an IgM coming in there, so that's called non-primary first episode. And then if I have both IgG, IgM negative, then obviously that's a previous infection which may never go away. And that's what patients worry about, that oh, this herpes is still there, but that's obviously a previous episode. Now, treatment, all of us know. I just want to talk about acyclovir, which is very safe in pregnancy. We see a lot of HSV in pregnancy. We can give acyclovir quite safely, 400 milligram 3 times in a day. Famciclovir, I'm a bigger fan of valacyclovir because it gives you lesser dosing, better compliance, a BD dose of 1 gram. Remember, and again I've seen a lot of physicians apply, ask and even prescribe a topical acyclovir, doesn't work, should be discouraged. Don't do that. Even for herpes labialis, don't do that. It's better to give you oral drugs. You might be increasing resistance by a topical drug, so don't give topical acyclovir. This is very important. We often give suppression for people who are having a recurrent episode. I like the last drug, valacyclovir, 500 or 1000 milligrams every day once. We give it for about a year. Okay. If you have more than 10 episodes, give 1 gram. If you have less than 10 episodes, give 500 milligram every day. These are very good. Why is it good? Because it reduces your frequencies by up to 80%. More importantly, it protects the wife if the husband is infected. So you want to protect the wife from getting herpes and getting a lifelong recurrence for her own. So give them suppression to prevent transmission to the partner. So this is very important. You can do this for your patients. Mimics of herpes. We see a lot of this again. We see people coming to us with recurrent ulcerations. Looks like herpes, but it's very classically something that we call as fixed drug eruptions. How do you differentiate that? The reason it's called fixed is because it returns on the same site. And all of them will have taken tinidazole or ornidazole, usually for loose motions or for a dental extraction. And the classical point is a bit of bluishness and a bit of lip lesion. And that is how you differentiate from herpes so easily. A lot of people who have fixed drug eruption get treated for herpes because both are recurrent. Now, this is again something we don't see so much, so we might have to skip this. I'll quickly talk about it. Classical syphilis. Okay, how do we diagnose syphilis? It's usually painless, it's usually hard, usually single in contrast to herpes, which was multiple, and there's no bleed. This is typically syphilis. We call it syphilis. Now, I want to show you, this is a very easy thing that we can just do in the OPD. You can just take your gloved finger and try to press. If it's hard, it's unpressable. It feels like a button, it's 100% syphilis. It's a very easy way, that's called a hard chancre. I think that will be easy way to understand. In your OPD, in your admissions, if you find any palm and sole lesion which is asymptomatic, which is non-itchy, which is an acral rash, most of us as physicians think of something like rickettsia. But there's one differential diagnosis, secondary syphilis, which is typically an acral rash. Okay. Investigation, I want to talk about this quickly. Okay. Testing protocol for syphilis, you always start with VDRL. Okay. If it's VDRL negative, you want to give, you say this is not syphilis. Straight away there. We know, or we can talk about a chancre. If it's positive, you have to do a confirmation test.
of TPPA, TPHA. If that is negative, then it is false positive VDRL. And if it's positive, then you want to treat them for syphilis. This is the standard treatment protocol. All of us need to follow that. This is how we want to really diagnose syphilis in patients. Let me just skip this. This is what we see most commonly. That, as sir said, somebody who's applying for a visa, get a VDRL positive report, okay, and a TPHA positive report, visa gets rejected, their career gets hampered, and then this is called latent syphilis. And this is some people who have had syphilis in the past, but then come to us. This is the commonest syphilis that we see nowadays, a latent syphilis, and then we'll tell you how the treatment is done. We'll skip this, please. This is a very important slide for all physicians. If your VDRL is positive, TPHA is positive, it's an active disease, treat them for benzathine penicillin. VDRL always becomes negative after treatment. Unfortunately, TPHA remains positive after treatment, right? So you will find that if TPHA is still positive, VDRL is negative, this is inactive disease, don't ever treat this. It is TPHA lifelong positive. If your VDRL is positive and TPHA is negative, this is false positive. And usually the titer is less than 1:8, that's a false positive. This is just a standard protocol that we would employ for syphilis. Okay, we'll not go into the treatment, I'm short of time. Just broadly speaking, you want to give benzathine penicillin, okay, intramuscular single dose for the early stages of syphilis, and the same benzathine 3 doses for the late stages of syphilis. Doxycycline if you can't give benzathine penicillin. That's what we would want to give, 14 to 28 days. We'll skip this. I'll talk about, this is the standard chart. If ulcers are recurrent, then you treat for herpes. If the ulcers are single, then you treat for chancroid and syphilis, which is benzathine penicillin plus azithromycin. This is standard protocol for people who don't have a vesicle, come to us with ulcers. Okay. What's very important, what treatment? This is human papilloma virus. I'll take 2 minutes more, not more than that, sorry. Okay. Treatment is usually this. All of us as dermatologists give imiquimod creams. For genital warts, very good treatment. It really improves them very fast. Podophyllin, cryotherapy, Cotri, and TCA. Usually for pregnancy, we only want to give TCA and cryotherapy, one of the best therapies we have for pregnancy per se. Now, will all of you know molluscum? Typically, you diagnose them by a little bit of this umbilicated papule. The moment I find umbilication, you know this is molluscum. One of the commonest STDs that we see, and we just basically extract it with a needle, cauterize the base, and that's the cure for this molluscum disease. This is usually how we do it. Just remove that kind of a molluscum, and that should be good enough, and then cauterize the base for that molluscum thing. Okay. Discharge, I'll just tell you, skip this discharge thing. Now, anybody who comes to us with discharge, 1 second please. Anybody who comes to us with discharge from the urethra, we actually use a combined therapy most of the times because it's very difficult to diagnose chlamydia. Okay? And then what we do is we usually treat for gonococcus and chlamydia together. Now, here we usually use cefixime, there we use doxycycline. And if I can combine them, then we know this is combination therapy. So if you give doxycycline and cefixime, we are through with therapy for most people who have a urethral discharge, gono and chlamydia together getting treated for patients. To finish with this quickly, this is something, just last 3-4 slides now for me. This is something that most physicians see as well in the OPD, a red glands. And most of us will think that's an STD. First point, it's not an STD. It is candidal balanitis, don't treat the partner. It's something that is not required. Most of these candidiasis are because of flora problems, and many of them already diabetic. Okay? This is easily treated, and we see this a lot with uncontrolled diabetes. This is called balanoposthitis, where there's a bit of phimosis, may not need surgery and circumcision. We don't want to suggest that. Give them diabetes control, give them antifungals, their phimosis goes away. Don't recommend surgery, please, for these people. That's balanoposthitis, and we see that a lot. Okay? Now, right, we may skip that, we may skip that. Okay, just one last point. Most of us as physicians, most of you might see SGLT2 inhibitors being causative agents for candidal balanitis and balanoposthitis. In fact, 3 times more chances. So one easy way, retract the superficial skin and ask them to urinate with that, so that the glucose doesn't touch the glands here. That's one point. Don't ask them to use a lot of irritating soaps inside. Ask them to use a cotton bud with cleaning that glucose which is coming through the urine, and that just reduces the ballonopotase. Right there, fluconazole is the best drug you can give for that particular situation. If it's recurrent, give them weekly fluconazole for 6 months. That's usually how you want to prevent their candidiasis, right? So I think this would then be overall something that I would want to do. For the lack of time, sorry if I exceeded my time. Thank you very much.
Thank you, Dr. Swaraj Jindal, for a wonderful presentation and beautiful slides. I have a question for you. Like, suppose a patient is having tertiary syphilis and she is pregnant also. How will you, and she is penicillin allergic, how will you treat that patient?
You say, okay, so that actually is a tricky situation. What at least theoretically happens here is something that we call as desensitization, which is usually done not obviously easily. It's something that has a protocol, and if I was honest enough, I have not seen anyone getting that through. Right?
That is what I was reading, and I thought it is one of the most difficult condition to treat.
Sure.
I mean, you have to hospitalize the patient,
Sure.
then you have to desensitize the patient with the
Sure.
penicillin.
So
Thank you. Thanks a lot.
A small comment on herpes, Saurabh. Very nice lecture. I was enjoying your lecture.
Thank you.
You know, when we do the typing, type 1 and type 2, these days a lot of oral sex prevalent. So type 2 gets positive in the herpes labialis also. So that's a practical issue, but that doesn't deter us from the diagnosis of herpes genitalis, because genitalis would be mostly type 2.
Thank you.
Thank you, sir. That was a very crisp lecture. I request all the faculty to proceed to the felicitation desk for felicitation. I request Dr. Rajiv Bansal to felicitate the speakers and chairpersons. Now I request Dr. Sumer Sharma to take over and start with the next session.
A very good morning to everyone present. Without further delay, I would like to start on the session on animal bites, clinical practice guidelines and management. And I would like to invite our speaker, Dr. Parul Kodan, the respected chairpersons, Dr. Naveen Atal, Dr. S.K. Gupta, Dr. Shubha Lakshmi, and Dr. Amitesh Agarwal on stage, please.
Thank you, sir. Good morning, everyone. When we talk about animal bites, I think we talk first the clinical presentation of rabies. So here I start with the presentation. Starting from the pages of history, the word comes from the word rabhas, which means to do violence, a Sanskrit word. This history of it goes back to the 1st century AD, and even decades and centuries later, we talk about this disease, which is very unique. It is 100% preventable and 100% fatal if not treated, or if the prophylaxis is not taken. Talking about the statistics, every 9 minutes someone dies from rabies. So even before we finish this lecture, somebody would have lost life from this preventable disease. And that is why I spare your thought on this disease, which is often neglected in our clinical discussions. Rabies is highly prevalent in India, with so many stray dogs and with bites every 2 seconds. It is a disease which is still prevalent in very high numbers. In 2023, statistics show that the numbers are actually increasing. Now, starting to what actually causes rabies. We are talking about animal bites. So can we have a raise of hands about which of the following animals will not be able to transmit rabies? Or what do the guidelines say? I mean, I hear a lot of cats, rats. So yes, most of you are saying house rat, and that is one thing which does not cause rabies. But do all other animals cause rabies? We know dogs definitely cause rabies. Okay, so now going down to what the guidelines or the data from India says. in India, more than 95% of cases are documented to be by dogs. And as we all know, dogs are the most common cause. The global statistics says 99% of cases when we are talking about rabies is dog. We're talking about rest of 1% when we're talking about the other animals. All the animals I've mentioned in the list is from NIMHANS data, and they have diagnosed it in some or the other animal in India having a positive: cat, monkey, mongoose, cats, buffaloes, horses, donkeys, pigs. These are rare cases, but the CDC guideline says you definitely need to treat if there's dogs, cats, skunks, raccoons, foxes, and bats. However, you can see the clinical scenario if there is any other warm-blooded animal. Theoretically speaking, all mammals can transmit it. However, there has been no Indian case reports by house rats, mice, rabbits, birds. Squirrels and bats were never reported in India before, but just a couple of years back, there has been one isolated case report of a squirrel causing it, and bats of Northeast with animals in caves, There has been no human transmission from them, but the bats in the caves of Northeast have been found to be rabbit positive. So we need to use the clinical judgment for all other animals, but there is definitely a strong recommendation for dogs. Now, which of the following route is not documented to transmit rabies? The lab personnel handling rabbit tissue, mother to child, corneal transplant, solid organ transplant, or hospital-acquired infections where hospital staff is handling a rabbit patient. Exactly. So as Sir has correctly said, mother to child, we've had no transmission. And also, there's a lot of fear. Just last month, I got a call from a friend who's an ophthalmologist in Gurgaon, and she had her cousin who was studying as a coaching institute in Gurgaon and had acute encephalitis. He was admitted in a hospital, and right there in the hospital, he was diagnosed as probable rabies because he had aerophobia and hydrophobia and laryngeal spasm. He was discharged the same day, and then unfortunately, he went from pillar to post, went to every government and private hospital over 2 days, but there was nobody ready to admit the patient. I do understand the social scenario, the problems of beds and all that, but there's also a fear of hospital-acquired infections. I get calls from my colleagues, nursing staff, residents, my own friends, that we have seen a rabies patient, now what to do? What is the chances? Should we go for a vaccine? But there has been absolutely no human case ever documented other than through surgeries. There is a one probable case, two non-lab confirmed cases of human-to-human rabies transmission from Africa and Ethiopia, which was by direct salivary contact, and that also is not a confirmed case. But only normal personal protective equipments, gloves, and the normal standard precautions should be enough in your clinical practice when you are treating with a rabies patient. There is absolutely no need to panic. As we know the structure of this virus, it's an enveloped virus. So just like any other enveloped virus, it gets deactivated by normal standard procedures. And we do not need to panic about a patient being dialyzed or a rabbit patient having had some treatment. There have been cases of corneal transplant. There was a 10-year-old girl who had bilateral congenital hereditary corneodystrophy. She had a keratoplasty done. 2 weeks later, she started complaining of headache. And subsequently, she died 16 days later. And the tissue showed, the whole brain biopsy of the patient showed that it was because of rabies. And the donor cornea was from a young male who just died for an unknown cause, said probably myocardial infarction, but this biopsy probably proves the cause of death. So this is one case which we often neglect in our differential diagnosis of encephalitis and the other cases as we are going to discuss. So just going broadly in the two major types of rabies, the furious one and the paralytic one. In interest of time, I won't be discussing the details of furious rabies because we know their absolute clinical presentation. What I want to concentrate now is a paralytic rabies because that's a scenario we often miss in our clinical diagnosis. It is often difficult to distinguish it from Guillain-Barré syndrome, and it is a very, very close differentiation, and it is very commonly seen. And it is very, very commonly seen in patients who have had a partial course of vaccine or who have not taken an immunoglobulin. And it's not rare to miss such a scenario. I'll take you through a case. A young boy, he was an adopted couple from Goa, and these are actual case scenarios. He had a sudden onset ascending paralysis. It progressed to respiratory failure. He required ventilatory support. And as all our intelligent residents would say it as a differential diagnosis, the first one would be Guillain-Barré syndrome. And same as everyone of us will consider, clinical diagnosis of Guillain-Barré syndrome was considered. He was given large volume plasmapheresis. he was given IVIG, but he succumbed to illness. And the distraught parents actually sued the hospital, and that's how this case went into an actual diagnosis, and the biopsy was done, and as we went through this, this is what we call the Negri bodies, a spot examination for a lot of it, and that clinched the diagnosis, and the hospital was not sued later. Was freed from this. So it was not the Guillain-Barré syndrome, but a very clinical presentation which looked very similar to Guillain-Barré syndrome, but ended up with the diagnosis of rabies. There is no absolute differentiation between the two, but in your clinical practice, there are a few markers which you can probably think in favor of paralytic rabies. Fever, paresthesias at the site of bite, a history of animal bite, quadriparesis with predominant proximal muscles, and urinary incontinence. Urinary incontinence is very rare in patients of GBS compared to the paralytic rabies data. And percussion myodema, if you see, may be present as one of the pointers towards a diagnosis of paralytic rabies. Moving from here to the good news is the disease is 100% preventable. And what we need is wound management, passive immunization, and active immunization. Post-exposure prophylaxis, the first thing you need if a patient comes is immediately wash the wound, use soap and water, apply 70% ethanol or iodine, as we just studied from the structure of the virus. Isolate the animal if possible, and then the active and passive immunization. Do not use medical and religious practices of using turmeric powders and witchcrafts. Do not try to suture the wound unless you have given an immunoglobulin, and do apply an antiseptic, a povidone, iodine, or an alcohol. Do not forget the wound management. It is very, very important. I have seen in busy rabies clinic where as soon as the patient comes, everyone wants to give vaccine. I appreciate that, and that is required, but do not forget wound management before that. It is a very, very important cause of failure of rabies vaccines. When we cause about true vaccine failures, they are absolutely rare. What causes the failure is an incomplete dose or an absence of wound management. So I would like to request you all to give a moment and do make sure that the wound management was appropriately done before you start with the classification and the treatment. The typical categories are category 1, 2, and 3, talking about WHO classification. Category 1 is when the animal licks an intact skin, and that's not where we are worried about. Category 2 is nibbling of an uncovered skin or minor scratches or abrasions without bleeding. Even this requires vaccine. I've seen people saying there was no bleed, so no vaccine is required. Minor scratches or abrasions also needs administration of vaccine. And then the 3 are what we call as the most important: single or multiple transdermal bites, scratches or licks on any broken skin, contamination of mucous membrane with saliva. So anywhere where you think that the saliva has touched beyond the skin, category 3 wound is there. If you have a differentiation or a problem in classifying, always choose the higher category, because it is 100% preventable, and on the other hand, 100% fatal disease. But most of the things would be actually covered by this. Although bats is not a major source in India, but exposure to bats is always classified as category 3. In category 3, what is important? Rabies immunoglobulin is very, very important. The cases which goes without immunoglobulin and only vaccines have a very high likelihood of failure and also chances of developing paralytic rabies, as we have just discussed. So a lot of cases of undiagnosed paralysis may actually go back to something which is very prevalent and yet ignored. So rabies post-exposure prophylaxis is infiltrate the depth of wound and around the wound. So how do we give the dosage? So we have rabies immunoglobulin, which can be human or equine. The most commonly used these days because of the allergy is human rabies immunoglobulin. And as a game changer we now have availability of monoclonal antibodies, which can be used in place of these immunoglobulins and work just like them. We need to infiltrate the wound and the area around the wound, and whatever dose is left can be given as an IM dose at a distant site. So now coming on to which of these conditions will you not give post-exposure prophylaxis? It's a pet dog bite who's apparently been vaccinated. It is a neonate who's just 2 days old. It is an HIV who's very immunocompromised patient, or pregnancy. These scenarios come to you with a dog bite. Would you proceed with the vaccination, or would you give benefit to any one of them? So So yes, there can be a lot of controversies regarding pet dog, which I will just go ahead. But to be very clear, there is no contraindication to this vaccine. Everyone who has been exposed to a dog bite must be given treatment. It is as simple. Pet dog bites are often raised, it causes a lot of concerns, a lot of questions, but I'll take you through case reports and the actual cases. This is a family from Chennai who brought home a 3-month-old pup. 2 weeks later, the dog was given vaccination, and the pet was bitten by a stray dog. The pet started biting everyone. They took him to a vet who said he needs pup training. Pup training was given, but the pet died 1 month later, and it was a lab-confirmed rabies. And unfortunate, and the very fact of the matter is, this is a doctor's family and a friend of mine who attended an ID conference with me. And it's so painful to tell that she had a daughter who ultimately succumbed to rabies. They are very educated, they have all the resources, all the means, but we cannot do anything if you actually have rabies diagnosed. So I want to just request and say that do not take anything. We say that pet vaccination is very, very effective. But when we talk about pet vaccination, we often do not know what vaccines were actually given to the pet. Were they just the rabies vaccine, or were they the other series of vaccine the pets get? The cold chain, the quality of vaccine, the way of administration of vaccines are another questionable facts. Ideally, a properly vaccinated pet should not cause this. But there are so many things beyond our control which we are not aware of. So it is always to err on the side of giving this 100% preventable disease a chance to save the life of a very valuable. And the unfortunate deaths are of young people who have no other illness. So we cannot take chances when it comes to this. So this is a 29-year-old female from Tamil Nadu who conceived by IVF after 6 years of marriage. She was bitten by a stray dog on her hand in her second trimester. It was said that the dog has been here in the colony for a long time and its pregnancy, and why should we take a chance? But unfortunately, she developed rabies in the 9th month of pregnancy, and the baby delivered by LSCS survived. However, the mother succumbed to rabies. And this is a case reported by NIMHANS. So we've had cases. So if at all, if I would like to say something, do not forget to give vaccines, and do not forget an immunoglobulin. Immunoglobulins have been a problem about the scarcity, availability. We used to run to specific centers. I think Safdarjung, RML, and AIIMS being the important centers in Delhi. But now we do have an option of monoclonal antibodies, which are doing pretty well. With the present available data, they are equivalent to immunoglobulins, although the data is still evolving, and a recent meta-analysis I did on it proved the fact that there are only 6 published studies with handful of patients, but the results are very encouraging, and this is available on the over-the-counter and can be used as in place of immunoglobulins as a very effective substitute. So types of vaccines is nervous tissue vaccine, tissue cultured vaccines, egg vaccines, and also an experimental oral rabies vaccine. In interest of time, I will skip this and would just go to the final schedule, which is 0, 3, 7, 14, and 28, if it is given by an IM schedule. There's a shortened SN regimen with 0, 3, 7, and 14. However, a lot of the places have now moved on to intradermal schedule, which is as good as an intramuscular schedule. The only thing is it should be given properly. The technique of giving is important when we are using this. So just the last thing about the post-exposure failure prophylaxis. As I've already said, true failures are very rare. It's often the incorrect advice, the incorrect regimen, or a delay in initiating PEP, which causes the disease. So now a boy comes with a history of dog bite 1 month back on a trekking trip. He was given vaccination as per schedule, but he was not given immunoglobulin. He Googled all the details and suddenly started panicking. What should I do now? Would you give him immunoglobulin? Would you give him vaccine? Or how would you proceed with this case? Okay, so the first and the foremost, we need to assess the bite, whether it was grade 1, 2, and 3. And if it happens to be a grade 3 bite, he should have received an immunoglobulin. But unfortunately, with the present data, there is no effectiveness of that beyond 7 days. So all that we can do is counsel the person and hope that he was not bit by a rabid dog. But there is nothing you need to give to this patient as of now. A 14-year-old girl who had grade 3 bite previously received post-exposure prophylaxis 1 year back. Would you prescribe her the retreatment now? Yes. So ideally, there's a schedule for patients who have been previously treated, which is a shorter one. But again, in the problems of cold strain and the vaccination series, how properly it was given, it is better to give a complete treatment. However, 2 booster doses of day 0 and Z3 is enough if the previous vaccination was given at a good center and you are pretty sure about the entire treatment being completed and the patient is under follow-up. No passive immunization needs to be repeated. Moving on to the last part of my thing. If there's a patient whom you're thinking of having a probable vaccine, these are the samples you're going to send. You're going to send saliva, nuchal skin biopsy, CSF, whichever of that is possible. I've sent a couple of samples as a resident to NIMHANS, but I think now NCDC in Delhi is also doing the same test, and that is where we can send the samples if you have ever suspecting it. Okay, now the last part is the management of human rabies. Unfortunately, if somebody develops the disease, how do we proceed? The Milwaukee's protocol has been told to cause human rabies survivor, and there have been case reports of rabies survivor where survival after treatment by induction of coma. However, to the best of my knowledge, every single case of rabies survivor has been in a non-dog bite or in a case of unconfirmed rabies. So the actual therapeutic paradox, which we say the maximum survivors are in India, is a bit controversial. However, giving the benefit of doubt, you can always go ahead with that treatment in conjunction with the critical care team. But the prognosis still remains poor, so the guidelines, and the only thing I would like to take away from this talk is never treat it lightly and do give an entire vaccination course when whenever in doubt. Thank you.
Thank you, Dr. Parul. That was a very enlightening talk. And do we have any questions from the audience?
Sorry, sir? So yes, it has been used in an academic purpose, definitely, where we are doing the antibodies titer, but I'm not aware of anywhere where it is done commercially. I know it is done in NIMHANS and it is done in AIMS and some centers where they are doing it more for academic purpose and as a part of a research. But I'm not aware of the commercial availability of regular antibodies testing. Sorry. Post-vaccination GBS. Sir, I think it is 300 mg per kg, but I'm not sure because there are different formulations. I'll just let you know once I confirm it after this talk. I'll come back and I'll let you know, sir. So, complications after the vaccine, it is often said, and it has been controversied in a couple of debates and in academic journals, that it is not the vaccine which is causing it. It is an improper vaccine, either the inferior vaccine or the incomplete dosage without an immunoglobulin, which actually caused that. Although there is, I do not have a definite data, but there are a lot of rebuttals going on about what actually incites that, and there's more in favor of the fact that it's not the vaccine dose which causes it, it's an improper vaccine dose which causes it.
Sir, we can take the questions later on because the sessions are getting delayed now.
Thank you, ma'am, for the crisp talk. I request all the faculty to proceed to the felicitation desk. I request Dr. B.K. Gupta to felicitate the speakers and chairpersons. Because of some unforeseen circumstances, we are having to delay the next session. We'll be taking up the session later. We'll be going to the approach to complicated UTI session. I request Dr. Neeru Agarwal, ma'am, to join us on the stage and start the proceedings of the session.
Good morning, everyone. The topic now is approach to complicated UTI. As all of us see that because of the growing geriatric population, diabetic population, it has become very, very important for us to define the line between simple UTI and complicated UTI, and there are many differences in the management of different types of complicated UTIs. So for this, the best person is General P.P. Verma. And few words about him. He is presently President of Indian Society of Nephrology. He works at Primus Super Specialty Hospital as HOD. He has many awards in his name, like Ati Vishesh Seva Medal. He was awarded NBE Illuminous Award in 2014 for outstanding contribution to the nephrology community. He has more than 1,000 transplants and more than 1,000 kidney biopsies to his credit. He superannuated from Indian Army after serving for 27 years and attained the rank of Lieutenant General. He was the honorary surgeon to the President of India in 2014 and 15. He has published more than 60 articles, contributed to many chapters in the different textbooks, and has more than 200 presentations. And he did his fellowship at Mass General Hospital and Toronto General Hospital. And as I know him, he is an excellent teacher, he is an excellent person, and very good orator. And I really feel that it is going to be a class, real class today on complicated UTI. Thank you.
Good afternoon, good morning, ladies and gentlemen. My profuse thanks to Professor Makkar and Professor Neeru Agarwal for giving me this opportunity.
Dr. Satish Chhabra, Dr. Varun Verma, and Dr. Rajesh Kesri.
Thanks, Professor Makkar, for giving me an opportunity to meet old and dear friends. I think Dr. Professor Chhabra used to organize this East Zone conference for many years, and I used to be one of the invitees in early, I think 2005, 6 or something. Thank you very much. Coming to the topic, approach to complicated UTI, I'll try to be brief. And UTI used to be a topic of nephrologists, but nowadays, I think general physicians, urologists, gynecologists do not allow the patient to reach the nephrologist, so it is being managed before reaching a nephrologist. We know that ladies, because of the short urethra, sexual trauma, and proximity to anus, are vulnerable for UTI, and almost 60% of the ladies in the lifetime will develop UTI. Mind you, if they develop UTI, almost 50% will develop recurrence of UTI. Menopausal women, the vaginal flora has got numerous bacteria, commensals, predominantly lactobacillus, and once a lady is menopausal, this lactobacillus flora changes, the estrogens are not there, the pH changes, they become vulnerable to UTI. Males are vulnerable by the extremes of age, either children or old people. We all know that UTI is a very important cause of hospital-acquired infections. Going by basics, if we have to classify UTI, we can say upper and lower. We can say uncomplicated and complicated. We can say community-acquired or hospital-acquired. What we are talking today is complicated to UTI. Why we call it complicated? Because the course can be complicated. There can be increased morbidity, need for hospitalization, more investigation, and longer treatment. That is why we call it complicated UTI. If you look at the European Association of Urology's definition for complicated UTI, it is here that all men are expected to have complicated UTI, pregnant women, anybody with relevant structural or functional abnormality, maybe a diabetic or immunocompromised patient, neurogenic bladder or reflux or stone, any structural or functional, and all patients with indwelling catheters are supposed to have complicated UTI. When we say recurrent UTI, basically, if there are 3 proven UTIs in a year, it becomes recurrent. Or if there are 2 proven UTIs in 6 months, it is recurrent. What we call catheter associated, catheter should be in place for at least 48 hours. Our catheter has just been removed in less than 48 hours back. person presents with fever or urinary symptoms, and urosepsis is, of course, a life-threatening organ dysfunction. What should be taken if we are trying to investigate a person? The best sample is suprapubic, or you put a catheter in and remove it out. That is the best. But both are invasive, not recommended. So therefore, the best other portion is midstream specimen, and this is supposed to correlate with what we get with suprapubic. Once you collect the urine, it has to be put on the culture plate within 2 hours. If you can't do it, and most of the times we can't do it, it should be refrigerated. Otherwise, the leukocytes will grow, the bacteria will multiply. It may be 10 raised to power 2, it will become 10 raised to power 6. The conventional definition of UTI is 10 raised to power 5 colony forming units per ml, but if a person is symptomatic, 10 raised to power 3 is enough. Some people will say even 10 raised to power 2 is enough, provided person is symptomatic. The correlation 10 pus cells per high power field in an uncentrifuged urine is equivalent. So you can see for 10 pus cells in the urine uncentrifuged. Don't ignore, on the dipstick there is a nitrite test and leukocyte esterase test. The WBCs, they have the leukocyte esterase, 10 type of leukocyte esterase. Whether living or dead WBCs, both have leukocyte esterase, so it is already there. So you can check for the leukocyte esterase if a person is symptomatic. And mind you, nitrite test is very good. But keep in mind, the urine has got nitrates. For conversion to nitrite, it takes 4 to 6 hours. Therefore, you have to take overnight specimen. The first specimen in the morning, and if you do that, I'll come to the next slide, but mind you, cloudy urine, smelly urine, mere urine mein smell aa rahi hai, cloudy hai does not mean UTI. If you look at the esterase and nitrite test, you will find, look at, the specificity is going to almost 95 to 98% if you have taken a nitrite test, and the positive predictive value, if you take both leukocyte esterase and nitrite test, it goes to 84% or so. So please don't ignore the nitrite test, which is on dipstick, provided it's an overnight specimen. The commonest organism all over the world remains E. coli, or coagulase negative staph, or Klebsiella, or Proteus, or Pseudomonas. They remain commonest, east or west, everywhere. Well, uncomplicated UTI. This is the guideline which is published last month only. IDSA in July 2023 guideline, which again says if you are treating uncomplicated UTI, any young female coming to you, no structural defect, UTI ho gaya after sexual trauma, you can give single dose of either aminoglycoside or single dose of phosphomycin, that is one. Otherwise, number one drug is, as on today, nitrofurantoin for 3 to 5 days, or Septron 3 to 5 days, or if last choice should be quinolones. The first two choices should be these. This is the recommendation as on today. A word about asymptomatic bacteria. We know more than 10 raised to power 5 organisms per ml, but patient is asymptomatic. Please do not treat. We have got a habit most of the time, patient report leke aaya 30 to 35 pus cell MI, treat kar do. Please don't treat unless a patient is symptomatic. Asymptomatic bacteria, you need to treat only if a lady is pregnant or if a genitourinary manipulation is contemplating. Third criteria may be if a person has received transplant in the last 3 months or so. If you look at why we say pregnant female, even there is a doubt coming nowadays whether asymptomatic bacteria in pregnancy should be treated. Some people are saying it doesn't require treatment now, but the old data shows that incidence of pyelonephritis, low birth weight, and premature birth are significantly reduced. So therefore, treat pregnant female with asymptomatic bacteria. What about, likewise, if you are expecting any urethral mucosa or urinary system mucosa breach by any manipulation, treat it night before or immediately before a person goes to OT. Coming to catheter-associated UTI, I thought that's the important thing. We should discuss that. We know that 20% of all hospitalized patients are on catheter. If you go to ICU, over 60% are on catheter. We know the daily risk of bacteria is 5 to 8% if you just put a catheter. That means if a catheter is in place for 15 days, 100% patient will have bacteria. And most of the UTIs in the hospital are catheter related. 25% of those with bacteria will develop UTI. Not all bacteria will develop. So they will develop UTI, and each day of each UTI, if a person develops, the hospitalization gets delayed by 4 days, and 20 to 40% of bloodstream infections originate from urinary tract. What is the definition of COTI or catheter-associated UTI? IDSA says 4 components. Urine culture, more than 10 raised to power 3. Symptoms of UTI, no alternative explanation, and the catheter was in place for at least 48 hours. That is the definition for IDSA definition. CDC says 3. The same catheter is in place for 2 calendar days. Symptoms, they take 10 raised to power 5 as the count. There should not be more than 2 types of growths. But however, we all follow this criteria, 10 raised to power 3 bucks, and a person is symptomatic. What are the risk factors? We all know the duration of catheterization, female sex, older people, diabetics. As Dr. Niru was mentioning, older people are more vulnerable. Bacterial colonization of drainage bag, errors in catheter care. That is the most important cause in the hospital. You go to the ICU, urine bag is lying on the floor. We don't know. It is lying there. Otherwise, you ask any sister, "Vaisa, culture kaise loge?" She will open the tap from below and take the culture. Please do not do that. Never open the closed system. The tube which is going, just clean it with betadine, put a syringe and take a culture. Do not take the culture from the bag, and don't keep the bag on the ground. Well, if you say how the bacteria reaches the urinary system, 2/3 of the times it is periurethral, the pericatheter. You have put the catheter, and 1/3 of the time it is luminal. How it happens? If you look at the incidence of COTI, Indian studies say 20% of the catheterized patient get it. USA says 13%. So that is a rough percentage. That means if you are keeping a catheter inside, that roughly 10 per 1,000 catheter days infections are likely to occur. If you have got an ICU of, let's say, 20 patients, or if they are all on catheter, that means in a month, 600 catheter days, you expect 5 to 6 catheter infections in a month. Now, the bugs, this is a network of healthcare network of US. This is 2011 to 14, E. coli. You come later on also, E. coli remains the commonest bug, followed by Klebsiella and Pseudomonas, and that is the data from India also. Now, if you look at this is the data from India, I think from Calcutta side, where they find 10 per 1,000 catheter days is the incidence of UTI, and their study Pseudomonas was the dominant organism. So pathogenesis is, once you put the catheter, there is periurethral, the bacteria which is lying there in a female or male, they will go up by pili and adhesions. We will not go to the complexities. They ascend up. Once they ascend up, they release proteases and toxin which help in getting the nutrition from bladder wall. And some develop siderophores by which they absorb the iron, and that is the best food for bacteria. Inflammatory response, neutrophils, they will kill. Some evade the immune system, multiply and form a biofilm. Some cause encrustation. We will come to that. Catheter causes The body releases fibrinogen. Fibrinogen is an anchorage for catheter, and the catheter sticks, the bacteria stick there. Protease, we all know, is a urease-producing organism which splits the urea in the urine to ammonia. Ammonia makes the urine alkaline, and in alkaline urine, the soluble component sulfate, phosphate, they crystallize. So that is how the crystallization is occurring if you are giving protease, if the bug is protease or Pseudomonas or Providentia. How do biofilm forms? The bacteria initially, the stages are reversible adhesion. The bacteria are sticking to the catheter. Then irreversible adhesion, colonization. Biofilm is nothing but a polysaccharide released by bacteria. It is their covering they make. And the covering is so strong that if you come, this is 200 to 300 times more protection to bacteria. So biofilm is forming immediately. The moment the bacteria start going up, they start making biofilm, which is a film all around them. And once the film is all around them, they multiply slowly. And all the antibiotics are effective against rapidly multiplying bacteria. So once the bacteria knows it has got a coverage, it has got protection, it becomes slow, quiet, and that is how they are not affected. So biofilm is a bad thing. We should try biofilm is not formed. Most of the antibiotics cannot cross the biofilm. This is just a film of the bladder. This is the facet cell, the bladder lining. What you see, the binucleate or pentanucleate cells leave E. coli. After 6 hours, you find the second photograph, all the cells are shed off. And this is third one. These blue are the shed off cells and red are the bacteria which are sloughing out. So they start acting pretty fast. If this is the catheter, I don't know if it has got a... Now this is what it is, the biofilm is forming on the catheter, and this is encrustation because of the, what you find is the sulfate and phosphates have crystallized. Does catheter material makes a difference? What you normally use catheter is what you call is a rubber catheter, a latex catheter, very soft, very malleable, it can just causes less trauma to the patient. But if you look at with electron microscopy, scanning electron, it is a rough surface. It allows biofilm to form. So please don't use latex catheter or normal rubber catheter if catheter is to be placed for a longer period. Silicone catheter is little stiffer than the normal rubber catheter, but it has got a smooth surface. The biofilm formation will be less. So it is safer if you are using catheter for just 1 day, latex is fine. But if you are using catheter for a longer period, use silicone catheter. There are many antibiotic-coated catheters, the antiseptic silver alloy, the catheter which are coated with silver, gold, palladium. And all these noble metals, they are oxidants. They cause repulsion of bacteria. So silver-coated catheter, gold-coated, these catheters are still there, but they are not much superior. So stick to silicone or latex. This is only if you see the silicone layer, how it looks. This is after bacteria have come. These are the other catheters. Now, if you look at the studies, they are only showing that if you put a silver alloy catheter vis-a-vis standard catheter, it is infection rate 35% reduction is there, but antibiotic catheter down below, they do not offer much of a protection. Some studies say they are good. Coming to diabetics, keep in mind diabetics are again a vulnerable group, 10-fold higher prevalence of UTI. More prevalence of pyelonephritis, and mortality is also much higher in diabetics. Take care of them. Sugar control has to be pretty good. A word about the emphysematous pyelonephritis, because the diabetics become prone for that. You require 3 things for emphysematous pyelonephritis or anything to develop. 1, poorly controlled diabetic. Number 2, impaired perfusion. So that means there has to be some obstruction or something, an infection with a necrotizing organism. So emphysematous cystitis usually is if there is a fistula, colonic fistula or vaginal fistula, but pyelonephritis and all, they are generally ascending infection. Pyelitis, we say if the gas is only in the pelvis. Pyelonephritis emphysematous has got 4 types. 1, the gas is only in the pelvic ileal system. 2, it goes into the parenchyma of the kidney. 3, it is outside the parenchyma of the kidney. 4, bilateral. So if a person has got this, so you have to, the E. coli, Enterobacter, these are the bugs. So you have to keep in mind that if a person has got only pilus, it is all right. If it is in the parenchyma, you will have to put an intercostal, what you call pigtail catheter for draining. And if it is in bilateral or stage 4, you will have to do nephrectomy. Points to remember, other setting is prostate. There is a residual urine, so you have to take care of the residual urine. It should not be there because that will be a focus of infection always. Stone disease, we know the urine itself, if it is a proteus, we discussed that it will cause alkaline urine. In alkaline urine, the precipitation is there, so there will be magnesium, ammonium, phosphate. That is a true white stone. Otherwise, if there is already a stone lying there, so it is a nidus for biofilm, it will make a person prone for infection. So if you are removing stone, treat before stone removal, and once you remove the stone, again treat for UTI. Some people again find this basically purple bag syndrome. So we all know that this is all due to 3 stages. The tryptophan in the diet gets converted into indole in the gut, and indole gets converted to indoxyl sulfate in the liver. Indoxyl sulfate gets converted to indirubin and indigo, red and violet color. This becomes purple. Don't get scared. Generally, diabetic ladies, ladies with constipation, ladies who are bedridden. So if you just give them relieve constipation, give them antibiotics, everything becomes all right. Now, if you look at the hospital-acquired infection, what is frightening today is, this is the data from India only, Goa, that almost 80% of the E. coli pseudomonas are getting resistant to the antibiotics. It is all our doing. Indiscriminate use of antibiotic by all of us. Look at the other multicentric study from India. Again, you find 50, 40, 100% are becoming antibiotic resistant to most of the antibiotics which are available, multi-drug resistant. This is the IDSA guideline, which has just been released. This is on 6th of July. So this is what it is mentioning today. Complicated UTI, if symptoms resolve promptly, 7 days is good enough. If a person is stable, you can give oral also. But if a person is complex, having fever, having sepsis, you will have to hospitalize him, and parenteral antibiotic is there. Keep in mind, culture has to be taken after the catheter removal. Once the catheter is in, don't take culture, there's no benefit. Remove the catheter, now take the midstream or whatever. If a person can't pass, remove the catheter, put another catheter, take a culture then. Because this catheter, old one, is infected. I can stop, or if you want 2 minutes, I will take 2 minutes. Remove the catheter. Now, this is the recommendation by, time was 30 minutes to me. It is mentioned 20 minutes here. All right. So anyway, the first line treatment remains Septron and quinolones. This is the treatment for UTI complicated. Aminoglycoside full course, equally good. Treatment today is meropenem. Penems, carbapenems are the treatment of choice for complicated UTI as per IDSA. If there is no response, then whatever ceftazidime, avibactam, meropenem, antibiotics which you should resort to. I will leave it. These are not useful. Now, even now, triclosan, farcosfil, they are coming which break the biofilm. And the lithostat down below is there to stop the urease splitting organism. Liquids, the trials are going on, they might come. The last one is the vaccines which are coming. Now, there are a lot of say goodbye to UTI, whatever people are trying to say. What it is that I will go straight to this. This is a data which has just come March 2023. That is showing MV140 polyvalent bacterial vaccine is coming. The trials, as the name here it is in stage 2 and 3 development and being tried in 26 countries. It is against all E. coli, Klebsiella, Proteus, Enterococcus. 25% cell wall is taken from them, and this is how it is acting. Basically, Th1, Th17 cells are proliferating, and Th2 is going down. I'll stop here. I will not give this because Dr. Swati is staring. Last slide. I'll skip it. Last, complicated UTI, we know, is an important source of bacteremia and hospital-acquired infection. We have to take care. Catheterization should be done only if required by a trained person and removed as early as possible. Silicone, silver alloy catheters are better if you are using it for longer period. Diabetics with stone disease, neurogenic bladder, prostate, they are vulnerable group. Look at the basic cause. Don't treat asymptomatic bacteria. These days with SGLT2 inhibitor, every patient comes with 30 to 40 pus cells. Please refrain from treating anybody. Treatment should be based on local resistance pattern, and I have given you the present guidelines. Vaccines may offer hope for recurrent UTI. I'll stop here. Any questions?
Thank you very much, General Verma, for a very lucid lecture on this. I know you could have taken at least another 15 minutes to go into the details, but sorry for the time constraint.
Perfect, sir.
Are there any questions from the audience, please? Yes, sir.
We'll take only one question.
I don't have any question, but I commend. It was an excellent talk. Thank you very much. Thank you very much.
Sir, it was a...
Thank you. I can only request Dr. Neeru to please close.
What is your
this
take
session.
on phosphomycin sachet? What is...
Yeah, phosphomycin sachet, only one sachet is required. Half a glass of water, dissolve in it, take one. That's all. That is for uncomplicated UTI. Phosphomycin is only majorly affected against E. coli. If it is other organism, it may not act. Keep in mind, nitrofurantoin, please don't give for upper UTI. Nitrofurantoin is not excreted through the kidney, it is acting locally there. So NFT is good for lower UTI. And if GFR is less than 45, don't give NFT also. Phosphomycin is good. The response rate they claim is almost 80%, but it is a very simple thing. If a patient can come on follow-up, like I said, 1 dose of aminoglycoside today. You have given, patient has come, amikacin, 1 dose, go back home. Previously, we used to say amoxicillin, 12 capsule, 3 gram, ampicillin, 14 capsule, 3.5 gram, single dose is good enough. Today, NFT, people are saying, are Septron 4 tablets, good enough. So they are also there, but the recommendation today is NFT 3 to 5 days.
Thank you, General P.P. Verma.
Recurrence should not occur.
We close the session here due to paucity of time. You can ask the questions later. Thank you.
Yeah, please.
A person who has taken phosphomycin should not pass urine, empty his bladder for 1 hour after taking drug. That is an important thing we have to tell our patients.
I request the speakers and chairpersons to proceed to the felicitation desk. I request Dr. N.K. Govil to felicitate the faculty. Now I request Dr. Anirudh Lochan to come over and start with the next session.
Thank you, Dr. Swati, and thank you to all the delegates for being with us since the morning. Now we come to the last session before we break for tea. The last session, the topic is SIRS, sepsis, severe sepsis and septic shock, when to suspect, when to prevent, and how to treat. Before I invite, the speaker for this talk is Dr. Akhil Taneja. Dr. Akhil Taneja is the principal consultant in critical care medicine at Max Hospital, Paparganj. In addition to being a practicing doctor, he is also a person who takes active interest in spreading education about critical care, as also about sepsis management, and he's also an authority on ARDS ventilation. And before that, before we start the talk, I'd also like to invite on stage the chairpersons for this talk. I'd like to invite on stage Dr. YP Singh, Dr. Manish Singh, Dr. Atul Bhasin, Dr. Harshita Tyagi, Dr. Manish Gupta, and Dr. Ashutosh Garg. May I have all the chairpersons on stage, please? I would now hand over the stage to Dr. Akhil Taneja.
So a very good morning to all present here, and my sincere thanks to the organizing committee for calling me here. So my topic for today's talk is SIRS, sepsis, severe sepsis, and septic shock. To start with, SIRS and severe sepsis. Now, these terms have been made obsolete by the latest definitions that have been presented in 2016. So to start with, sepsis is difficult to define. It is described more than 2,000 years ago. It was been a mystery since then. Most of the patients, they will not present with the florid manifestations. Quite a lot of hidden or occult sepsis is there. So increasing pressure for widely deployable consistent definitions, and there is complex pathophysiology. So moving forward, this was the first definition of sepsis given in 1991, and then this was modified in 2001. And since last 2 decades, they have been unchanged till 2016. So what was the problem with these kind of definitions? They were SIRS based or SIRS based, having a term severe sepsis, and there were different criteria used in different definitions. So these are the SIRS criteria: the temperature less than 36 degree or more than 38 degree, heart rate of more than 90 beats per minute, tachypnea more than 20 breaths per minute, or a partial pressure of carbon dioxide less than 32 mmHg, WBC count more than 12,000 or less than 4,000, along with more than 10% band cells. So these are the criteria for SIRS. Now, what these older definitions used to do, they used to say if there are more than 2 criteria present, it is SIRS or systemic inflammatory response syndrome. Then if there is infection suspected or presumed or confirmed, this is sepsis. When there is organ dysfunction involved, it is severe sepsis. If BP is going low, this is septic shock. And if more than 2 organs are involved, this is MODS. So this was the initial definition of sepsis going on for last 2 decades. Also, coming to the SIRS sensitivity. Now, these 2 studies, they were published in 2015 in NAGM and American Journal of Respiratory Critical Care Medicine. Now, what they say, 1 in 8 patient was missed who was having sepsis and had mortality by using this criteria. This study said that almost half of patients hospitalized on the wards developed SIRS at least once during their ward stay. Our findings suggest that screening ward patients using SIRS criteria for identifying those with sepsis would be impractical. Now, these are the issues with the SIRS definition. So, SIRS per se is an appropriate response to infection or any other stimulus that activates inflammation. Secondly, coming to the term severe sepsis, the severe sepsis, it is a confusing term. Most people say sepsis when they actually mean severe sepsis. Now, this is a very classic presentation. These are 4 different studies. They used 4 different criteria to identify severe sepsis, and number of patients based on different criteria were different in all 4 studies. Mortality was different in all 4 studies based on different criteria. So what were these different criteria? Some studies, they take MAP of less than 60 or less than 70. Some take fall in systolic arterial pressure of more than 40. considering lactate levels, some take more than 2 or some take more than 4. As far as inotropes and vasopressors are concerned, some define their dose, some do not define their dose. So based on these criteria, they have identified severe sepsis differently. That made a lot of difference in results, and mortality came out to be different. So based on this, findings of SIRS and severe sepsis, in 2016, the task force defined sepsis in a new way and gave a newer definition to sepsis. So what is the newer definition? Sepsis is life-threatening organ dysfunction caused by a dysregulated host response. Now, two things are very important here. One is organ dysfunction, one is dysregulated host response. Now, previously it was sepsis with organ dysfunction, which was severe sepsis. And it was any response, which was sepsis. Now, it is a dysregulated response, and then there is organ dysfunction. So sepsis now is the old severe sepsis. And secondly, it is dysregulated host response as opposed to regulated host response, which is SIRS. Moving forward, definition of septic shock. Is septic shock a sepsis where dysfunctional organ is the cardiovascular system? No. And what tangibly differentiates septic shock from sepsis? It is the mortality. So septic shock is a subset of sepsis in which the circulatory, cellular, and metabolic abnormalities are associated with greater risk of mortality than with sepsis alone. So these are the criteria for identification of septic shock. A MAP sustaining above more than 65 with requirement of vasopressor after adequate fluid resuscitation and serum lactate of more than so. So the point to note here is and, it is not or, it is and. So BP has to be maintained with vasopressors after adequate fluid resuscitation, and lactate has to be more than 2. Then it fits in the definition of septic shock as per current standards. So this is a spectrum: infection, sepsis with a mortality of 10%, septic shock with a mortality of approximate 40%, and morts with approximate mortality of 50%. So this goes in a spectrum, and differentiation between sepsis and septic shock, tangible difference is mortality. Now coming to prevention of sepsis, these are the preventive measures. Hand hygiene, as we all know, is the most important measure. Then environmental hygiene, screening and cohorting the patients, surveillance, antibiotic stewardship, following the guidelines or evidence-based medicine, and then safety culture in the institution. Coming to bundle care, what is bundle care? We have a set of interventions that are established practice, and when combined together, they make a bundle. Now the hypothesis is when bundle care is given, the 1 + 1 is not 4, it becomes 6, 7, or 8. So all the interventions done together in a protocolized way give better benefit than single intervention done independently. So this is an all or none phenomena, and application of all interventions is consistent for all patients at all times, thereby improving outcomes. So these are the bundles that we use in our setups, like WAP bundle, COTI bundle, CRBSI bundle, not going in details of them as of now. Now these are the Surviving Sepsis Campaign guidelines published in 2021. Now what they say for screening of the patients, for hospital and health system, we recommend using a performance improvement program for sepsis. Now they recommend a performance improvement program. So they say you constantly keep on screening the patients for sepsis and giving feedback to the counterparts. So what are the screening tools? Number 1 is vital signs, signs of any other infections, quick SOFA, SIRS. Now SIRS has got a role in screening of sepsis, not diagnosis of sepsis. Then NEWS and MUSE, these are National Early Warning Score and Modified Early Warning Score. They are used in UK. So SIRS criteria we have already seen, still useful in helping to form a provisional diagnosis of infection, and appropriate but not necessarily dysregulated host response, and it has its place in screening, not in diagnosis. Coming to NEWS, this is used in UK, so these are the parameters: respiratory rate, oxygen saturation, oxygen temperature, BP. They give a scoring based on the values, and total aggregate is calculated. If it is 1 to 4, the risk of sepsis is low. 5 to 6, it is medium risk, and 7 or more, it is high risk for sepsis. Quick SOFA, this was a new parameter proposed in 2016 guideline to identify sepsis early and escalate therapy early. So what they say, Quick SOFA is a combination of 3 parameters: GCS, any GCS less than 15, tachypnea more than 22, and any BP systolic of less than 100. So 0 to 1 point, it is not a high-risk case for sepsis. If there are 2 or 3 points positive, you escalate therapy, you try and identify sepsis, you shift the patient to appropriate care and send appropriate labs. So again, screening tools, the guideline, the latest guideline says we recommend against using quick SOFA compared with SIRS, News or Muse as a single screening tool. Moving forward, for adults suspected of having sepsis, we suggest measuring blood lactates. Now, what is the role of lactate? The point number 2 here is important. Presence of an elevated lactate level significantly increases likelihood of final diagnosis of sepsis in patients with suspected sepsis. Now, if the initial lactate is raised in a suspected patient of sepsis, the final diagnosis will come out to be sepsis is very highly likely. But again, not sensitive, not specific. So no single parameter is good enough to identify sepsis. So we need to do a multitude of things and then use our clinical judgment. So this is a framework which is provided. Are you concerned that your patient could have sepsis? Consider the following risk factor. Now these are the general risk factor: representation to system or hospital or ICU within 48 hours, recent surgery, indwelling catheters, immunocompromised status, age more than 65 and fall. Absence of risk factor does not exclude sepsis. Then there are other signs: fever, dysuria, cough. So all the signs of organ dysfunction. Plus, if there is any red zone like systolic BP of less than 90, lactate of more than 4, or base excess of less than 4. So moving forward, if they are going to the red zone, this is sepsis. Patient has severe sepsis. He has got organ dysfunction with hypotension. So patient has got sepsis with septic shock, unless until proven otherwise. If we are going to the yellow zone, 2 or more yellow zone observations are there. If yes, so patient may have sepsis. We need to do a further follow-up and constant re-evaluation. And if no, patient is probably not having sepsis, and we need to look for any other cause of acute decompensation and treat it accordingly. So that is the framework which is provided in the NHS guidelines. Now coming to the management part, now this is a very broad topic. I've got some 90 guidelines over that in Surviving Sepsis Campaign guidelines. I'll just discuss a few of them which are important clinically. So there are currently no licensed pharmacological treatment for sepsis, and early recognition and treatment, particularly early administration of effective antibiotics, are associated with decreased mortality. Now this is a 1-hour bundle which is proposed. They say patient have presented to you with sepsis or presentation like sepsis, and you are suspecting or presuming it to be sepsis. You need to do following 4 things in 1 hour. That is, measure lactate levels, obtain blood culture before administering antibiotics, administer broad spectrum antibiotics, begin to rapidly administer 30 ml per kg crystalloid for hypotension or lactate of more than 4. So these 4 things we have to go ahead with. Initial resuscitation. For patients with sepsis, induced hypoperfusion or septic shock, we suggest at least 30 ml per kg of IV crystalloid. That should be given within 3 hours over period. Now, which fluid? Balanced crystalloids they have preferred over normal saline. And lastly, albumin in patients who have received large volume of crystalloids. Now, only thing to be discussed here is 30 ml per kg. Now, this seems to be insane in patients with acute respiratory failure or CKD or those with oliguria. So a framework has been provided. So we have sepsis-induced hypotension or lactate of more than 4. There is no requirement of high-flow oxygen, no ESRD, no dialysis requirement. You give rapid infusion. Rapid infusion means over 3 hours here. Then patient is having pneumonia or acute lung injury, high oxygen requirements, non-intubated or mechanically ventilated. You consider intubation, facilitate IV fluid infusion, and give 30 ml per kg. Patient is already intubated, not having high airway pressures, go with 30 ml per kg. Patient is ESRD on hemodialysis or congestive heart failure. A total can be given with frequent reassessment of oxygenation. Moving forward, what is the MAP target? MAP target is more than 65 mm Hg. It is not an all or none phenomena, then one size does not fit all. So there are special conditions where we need to target higher MAP, like chronic poorly controlled hypertension, intra-abdominal compartment syndrome, and high CVC with acute decrease in renal perfusion. Admission to ICU. Now, the rationale here is that bundle compliance is more in a critical care area. So as soon as you identify sepsis or septic shock, try and move the patient within next 6 hours to a designated critical care area so that better critical interventions are done. So that is the rationale here. About antibiotic timing, what is the guideline? They say if sepsis is definite or probable, you ideally administer antibiotic within 1 hour. If it is possible and shock is present, give it within 1 hour. Shock is absent, you do a constant reevaluation, you do a rapid assessment. By rapid assessment, they mean rapid assessment including history and clinical examination. Within 3 hours, you decide whether it is infectious cause or non-infectious cause. It is infectious, give antibiotic. It is non-infectious, acute cause, treat it. Still in dilemma, give antibiotic. So that is the guideline here. So coming to empirical antibiotic therapy, we all know we have to give it as per the PKPD concentrations guidelines and also site specific. These are the risk factors for MDR pathogens and MRSA. We are aware of them. And vasopressor management, norepinephrine is the first line vasopressor. Target map is 65. And consider invasive monitoring of arterial blood line. If central access is not there, we can give it peripherally, but they say give it proximal to antecubital fossa and not more than 6 hours. Patient is still hypotensive, add vasopressin. If there is evidence of cardiac dysfunction, add dobutamine or epinephrine. Additional therapies, hydrocortisone, only for those patients who have been fluid resuscitated, vasopressors have been started. They are still hypotensive, start with hydrocortisone. No positive recommendations as of now for polymyxin B filter or cytosol filters. Additional therapies in ICU, including mechanical ventilation, renal replacement therapy, nutrition, and glycemic control. These are as per the policies. Venous thromboembolism, blood transfusion, they say restrictive, less than 7 is the transfusion trigger, other than acute MI, severe hypoxemia, or hemorrhages. So to conclude my talk here, these are the inherent challenges in defining sepsis and septic shock. Sepsis is a broad term applied to an incompletely understood process. There are as yet no simple and unambiguous clinical criteria or biological imaging or lab features that uniquely identify a septic patient. Updated definitions of sepsis and septic shock have been proposed, which better identify patients. And finally, early recognition, resuscitation, immediate management with oxygen, cultures, antibiotic, and fluids. These are the cornerstone to the management. Thank you. Thank you very much.
Dr. Akhil very nicely presented the topic.
Thank you.
So, any question from the audience? So, most of the part has been covered, almost the treatment part and.
So, I've tried in my little time.
So, it's a very lengthy topic. So, any comments?
Very well presented. I think 20 minutes is a very short time to present something like sepsis. Just a few words. One thing which is very important is that sepsis is basically a multi-dimensional disease, or it's a syndromic disease which we need to treat very aggressively. Yes. And it has got a very roller coaster kind of a ride. If you treat the patient for 10-15 days, there's lots of physiological reserve which is available, which should be definitely utilized. I think we have got lots of terms which can be complicated to many young students. So we need to initiate. And for SIRS, there's a small thing which I used to use, that whenever you see a patient, the most important thing in SIRS is, first is suspect. If you're suspecting, initiate your treatment immediately, review your investigation subsequently, and if you're not able to do it, again, go for the 4th S, search again. You will definitely find a cause and you will be rewarded once you have done your best. Because there is no absolute guideline how to go about treating with antibiotics. That will evolve over the period of time as you see the patient. That's all.
So guidelines, they keep on changing with time. What we were treating 15 years back, the guideline has changed. Probably we have given more mortality 15 years back with those guidelines. So they keep on changing, we keep on evolving.
First of all, I want to congratulate Dr. Akhil to cover such a vast topic in 20 minutes. And one question I want to ask, which albumin you will recommend for the resuscitation purpose?
So for resuscitation purpose, 4% and 5% albumin is recommended, and it's commonly available. 20% albumin is not recommended for resuscitation purpose.
In
5% albumin.
In what doses?
So we start with a bolus of 200 ml to 300 ml. We go ahead with 40 to 60 ml per hour. So it is in the 3:1 ratio to the crystalloid actually. So if we are giving crystalloid 100 ml per hour, 120 ml per hour, we go with 3:1 ratio for crystalloid to colloid. So we go with 40 ml to 50 ml per hour of 5% albumin for that.
So very nice explanation. Basically, when we use large volume resuscitation, we should not use crystalloids. We should use 4% or 5% albumin, which are available for the large volume resuscitation. This is the take-home message.
Thank you.
Thank you, sir, for covering such a vast topic in a shorter time. I request the faculty to kindly proceed to the felicitation chamber desk, and I request Dr. Anil Chaturvedi to felicitate the chairpersons and the speakers. And now I would like to invite Dr. Naresh Agarwal to start with the next session.
Unfortunately, because and he has been a great teacher to many of the alumni of GB Pant. He is DM from SGPGI Lucknow, and apart from his academic gastroenterology career, may I share that he has a great interest and a competent interest in wild bird cinematography. And he's a great person to do a calligraphy as well. So this is my great honor and privilege to invite him to the dais for his talk on approach and management to chronic GI tract infections and chronic infective diarrheas. Dr. S. Puri, please come, sir. Yes. And for this session, we have esteemed gastroenterologists to chair the session, and may I invite Dr. Neeraj Jain. He is head of the department at Pushpanjali Medical Center in the Department of Gastroenterology. Dr. Deepak Lahoti, the head of the gastroenterology at Max Super Speciality Hospital, Patparganj. Dr. Vibhu Mittal, he is the associate director of gastroenterology at Max Super Speciality Hospital, Patparganj. And Dr. Sushrut is the consultant gastroenterologist at Fortis, Noida. Thank you so much.
Thank you, Dr. Naresh, for the kind introduction. And it's an honor that I have on the chair senior colleagues. Dr. Deepak was my senior, and Neeraj Jain. So, and thank you to the East Delhi Physicians Forum for giving me this opportunity. This is essentially that was work done at GB Pant Hospital when I was there for almost 25 years. And so when Naresh told me that he is going to give me a talk on chronic infective diarrhea and to give both a diagnostic approach as well as how to diagnose and treat them, it was a complex task, so I've tried to simplify it, and I hope I can get the message across. The first and foremost message that I want to give is that chronic diarrhea is not a symptom. It is a symptom, it's not a disease. So many times we see the patients who have been having a chronic diarrhea, they just get one course or the other of antibiotics, starting from Brifagut, quinolones, and what have you, and in the hope that these patients will respond, and they don't, because you're not able to get to the proper root of the problem. And there is no Ramban that you can hit and the patient is going to be all right. So you have to actually diagnosis is the most important thing. The problem with India as compared to the West is that in the West, most of their chronic diarrheas are non-infectious, such as IBD, celiac disease, chronic pancreatitis, etc. But in India, we have all of their problems, and we also have our own problems. Mainly, we have parasitic infections, we have viral infections, we have bacterial infections, and the West only became aware of the infections when the AIDS epidemic hit them in the 80s. And then all of a sudden, there was a sudden interest in all these pathogens which cause chronic diarrhea. Otherwise, the spectrum of disease is so different in the East versus West. So this is what we have kind of put together, and how do you approach a patient who has a chronic diarrhea in the tropics. We're talking specifically of India. It's better to lump it is better to lump two symptoms together, chronic diarrhea and anemia. You put these together, and then you will have two broad categories, and those who have an anemia and those who don't have an anemia, saw anemia. In that case, we will have IBS, drugs, etc. But the most important entity that is that is likely to be missed in this category is HIV. And I am very wary. So whenever a young patient comes to me with chronic diarrhea, the first thing that I get out of the way is HIV. And once that is sorted out, then it becomes more or less, because suddenly HIV, all of a sudden you will have some kind of bizarre infections, uncommon infections, and unless you're well versed with them, you'll just keep on looking for the diagnosis. Most patients with chronic diarrhea do have anemia. And as you know, whenever you approach anemia, there's only three categories: iron deficiency anemia, ACD is anemia of chronic disease, and diarrhea is the simplest, because essentially you're left with tropical sprue, which used to be very common specifically in South India, but it was all over, and small intestinal bacterial overgrowth. In anemia of chronic disease, what you need to exclude is basically tuberculosis. And for iron deficiency anemia, the one organism which can really cause a problem is strongyloidosis, and I'll discuss that subsequently. So in these patients who do not have anemia, as I said, my approach is first get HIV out of the way. I will do a HIV, I will do a CD4 count if that is positive, and screen the stool for opportunistic infections. You have a good tie-up with your microbiologist, they'll do the special stains, you sound them, and you will get the results within a day, minimum cost. The others, sometimes you need to do a colonoscopy, you might need to do a C. diff in an elderly patient who's been in hospital, who's received multiple antibiotics. CD toxin is very much on the cards. As I said, those with megaloblastic anemia is almost probably the simplest to treat. Previously, we were doing bone marrows. Now, nobody does bone marrow to diagnose megaloblastic anemia. We have B12 and folate levels. And if that suggests, then you can go ahead with either ileal biopsy or duodenal biopsy. If you want to diagnose tropical sprue, the best thing to do is to get a CT enterography, because you don't want to miss a blind loop, you don't want to miss intestinal pseudo-obstruction, which is causing the small intestinal bacterial overgrowth. So these are the only two categories that present as diarrhea and anemia. In these patients, if you have patients with severe, specifically with iron deficiency anemia, what you need to get out of the way is strongyloidosis. The trouble with strongyloidosis, if it's mild, it causes a profound eosinophilia. But when it causes chronic diarrhea, when the patient has a protein-losing enteropathy, the eosinophilia disappears and you never think of it. It's a very patchy disease, and unless you really go after it, you can miss it. I'm going to skip this slide because tuberculosis, even now, is still very common. We diagnose it on the clinical basis, patients presenting with fever, diarrhea, and I prefer to do a first line is a CT enterography, and thereafter my approach is to do a colonoscopy and a biopsy, and if required, we might do a retrograde or an antegrade enteroscopy. When we're investigating a chronic diarrhea, the most important person is the gastroenterologist, and specifically it's the endoscopist. And the endoscopist is able to see things for himself. Sometimes you just look at the patient from inside and you get the diagnosis. And otherwise, we have the ability to take biopsies, and the biopsies will give you a whole plethora of information. You can make the exact diagnosis. So the second part of my talk, which I'm going to start now, is basically a visit to the zoo of the intestinal gut. And here, the most important thing is histology. And as you can see, I've ticked something. So in these conditions, the histology is diagnostic. If you get caseating granuloma on your biopsy, uncommon, but if you get it, diagnosis is made, shut the case and start the treatment. Giardia, Whipple's disease, strongyloidosis, cryptosporid, all these are easily, absolutely 100% specificity, no mistakes. And sometimes the histology is suggestive. For example, if you have a patient who has a non-caseating granuloma, then you have to think, does he have Crohn's disease or is it tuberculosis? And that's a different story altogether. In tropical sprue also, you just get some degree of villus flattening, so you have to rule out the other causes. Now, what are the other aids? We can take endoscopic biopsy, and what you should tell your histopathology or pathology clues is, in this patient, I'm suspecting this. So not only do you have to do the routine H&E, please do IHC, which they will do anyway. Please do special stains like ZN stain, PAS or Gomori if required. And you can even do a wet mount, which I will talk about it later. So this is a visit to the zoo now. This is sometimes the patient will come and she will tell you the diagnosis that I was passing diarrhea many times, and along with the stool something abnormal used to come out, and finally one day she'll take a picture and bring to you, and the whole Tinea saginata, entire thing is expelled. It's easy to treat, praziquantel, 10 milligram per kilogram, single dose, and the diagnosis is shut. Fasciola buscae, not common in North India at all. This is from Panth. A patient came from Bihar, young girl, and she was vomiting and she was having a chronic diarrhea. And the mother used to say that she is vomiting rice when she doesn't eat rice. And that, we just ignored that the mother is. And then one day she vomited in the ward and we found these rice particles. And suddenly when I looked at it carefully, the rice particles were moving, and it was actually Fasciola buscae, which is exactly the size of a rice particle. And unfortunately, we lost this because she had a disseminated Fasciola buscae infection. As I said, what I learned at Panth was chronic diarrhea comes in all shapes. I think we had a lecture earlier in the morning in the session on the STD. So I'm very wary. And the three organisms that you need to consider in patients presenting with diarrhea is Cryptosporidia, Isospora, old name, new name is Cystoisospora, and Microsporidia. And the best part is at least two of them can easily be diagnosed on just a stool examination with special stains, which is a modified AFP. So this is, as you can see over here, this is a wet mount. The microbiologist picked this up, and for us, she said, okay, I'll stain it. And what you can see is about a 22 microns across, violet, magenta colored, pink, and this is classically an isospora. You don't have to do any other investigations. This patient, we did do biopsies, so in my subsequent slide, I will show you what it looks like. This is a typical appearance of amoebic ulcers. When you see this kind of a picture, I actually think you don't have to take a biopsy. There is no other disease which presents with ulcers like this. They are typically always multiple, and I tell my residents, one swallow doesn't a summer make. And similarly, if you have one ulcer, please don't consider amoebic. So this is typical ulcers. They're always clustered together. They have this normal intervening mucosa, and they're covered by this whitish exudate yellowish because of the bile salts, which is called a poached egg appearance. And the favorite sites are rectosigmoid and the right colon. And for those not very familiar with poached eggs, this is what they look like, and this is what the ulcers look like. And this is something that we did at Panth. It is unique. This is a real-time movie. I hope the movie. So what you can see over here is one amoeba over here, one amoeba over here, and this amoeba is going to eat this RBC. And you can just watch the movie, focus on this, and this amoeba is
sprue. Both these entities now we are seeing much less common as compared to 2 decades before. In fact, maybe the definition of tropical sprue has changed altogether. What are your views? HIV in chronic diarrhea, we do this testing in most of our patients, but we are not seeing as many patients.
So I'll take the first question first. It depends on what strata of population is coming to you. If they are coming from the higher socioeconomic status, and you're not dealing with patients who are drug addicts or patients who are from the lowest socioeconomic strata, who are sexually promiscuous, that is where you will still get it. So it depends. In Panth, we had a lot of people coming in from the lowest socioeconomic strata. So that is why we were able to pick up all this. This is collected over the years. Regarding tropical flu, I agree with you completely that at one time it was endemic in the south. There was endemic variety, there was epidemic variety, and then there was the sporadic variety. So now and then, maybe 5 to 6 cases, maybe 10 cases in a year I would still see. And here, what I make sure is I do a CT angiography, because a blind loop, an internal fistula, anything will give rise to a diarrhea which responds to antibiotics. So for tropical flu, one of the essential criteria should be that there should be no mechanical obstruction or fistulization. And that can only be ensured by a CT angiography. If you have after that anemia which is dominant and a megaloblastic with MCV going up to 120 with very low levels of B12, you are justified in making a diagnosis of tropical flu and treat it accordingly. Sorry. What about amoebic diarrhea?
And again, what is your view about it?
What you're asking me about amoebic colitis? Now, there is true amoebic colitis, and at one time IBS was thought to be that this is a infection due to EH. Now, cysts don't cause anybody who has cysts in the urine, in the stool doesn't have amoebic colitis. The patient with amoebic colitis, if it is on the left side, is going to have blood in the stools. If it is on the right side, he may or may not have blood in the stools, but the diagnosis should be confirmed by doing an endoscopy, a colonoscopy, and you'll pick up the poached eggs over there.
So do you believe in chronic amoebic colitis?
No, I wanted to say I don't believe in God and I don't believe in amoebic colitis.
One question though, how often do you use biofire?
Very good question. I think it's a very useful test. I should have said that, because if you combine it with the histopathology, all the IHC and the special stains and the biofire, it is an excellent test for picking up giardia in post-renal transplantation, non-invasive technique, and I find the specificity is very good. The only issue is cost. So if somehow the cost can be brought down, the biofire or the PCR-based test is an excellent, excellent test. Stool culture, unfortunately, has now been relegated to maybe done occasionally. So if a patient comes to you with specifically with a florid bloody diarrhea, and when you are suspecting very highly that this could be Shigella or EHEC, enterohemorrhagic E. coli, that is where stool culture will help. EHEC can also be picked up by a biofire. The trouble with EHEC is that most of us would just say, oh, this is E. coli, so let us not treat it. But the point is this: if it is EHEC 0157, then that is the one that causes an infective colitis in which the whole of your colon is literally on fire and it resembles Shigella. But the good thing in most patients, it is self-limiting.
So, thank you, sir, for this comprehensive pack of information and education on chronic infective diarrheas in 30 minutes. No can be better than this. Thank you so much for your coming, sir. Thank you, sir. And thank you, Dr. Lahoti and Dr. Neeraj Jain, for your presence.
Thank you, sir. Request all the faculty to proceed to the felicitation desk. I request Dr. Rajiv Lochan to felicitate the faculty. Now I request Dr. B.K. Gupta to start with the next session.
Good noon to everyone. Now the next topic is approach tropical infection of the CNS. It's a very important and difficult topic. Approach to diagnosis and management. First, I request the chairpersons to come on the dais. Dr. Professor K.S. Anand is formerly HOD Neurology RML Hospital with a professional experience of 33 years, and he has published large number of scientific papers and chapters in international and national journals. Then Dr. Vivek Kumar, he is a Senior Director and Unit Head of Max Institute of Neurosciences, Patparganj. He had 11 publications in national and international journals, and special interest in stroke, headache, epilepsy, and movement disorders. For the presentation, I found none other than Dr. C.S. Modi, who has a lot of personal work for the CNS infection. Dr. Modi. He is a professor and Department of Neurology from PGI Chandigarh, and his areas of interest are CNS tuberculosis, CVT, neurocystic sarcosis, and Japanese bee encephalitis. Sir, over to you. Thank you.
Thank you, Dr. Gupta, Dr. Makar, and the East Delhi Society of Medicine, and for inviting me to discuss a topic which is really close to my heart. I've been specifically asked not to discuss all the tropical infections, which is actually not possible in half an hour, as you are all aware of it. So I'll be focusing predominantly in my talk on tuberculous meningitis. That's the thrust area of my research as well as my work also. But to start with this topic, I'll first enumerate the causes of febrile encephalopathy or febrile encephalitis syndrome. So infections are just one of the most important causes of febrile encephalopathy, especially in tropics, especially in India. But one should remember that there are a number of causes which can cause fever with altered sensorium. And in addition to CNS infections, it can be just septic encephalopathy, it can be neural malignant syndrome, it can be malignant hyperthermia, it can be heat stroke, it can be edema, it can be even subarachnoid hemorrhage, or a number of other non-infectious causes of CNS diseases which can produce febrile encephalopathy. So looking at this list, it really becomes difficult to diagnose and manage these conditions. But if we go systematically, as I had seen that in most of our lectures, there had been a real systematic approach of a good history, a good examination, and then diagnostic tests. Most of the time we are able to zero down, though may not be able to find out the exact cause of infection, but we can still figure out what we are actually dealing with. The emphasis will be more on how to approach really a patient who has come to you with acute febrile illness and altered sensorium. Of the infectious causes, there are hundreds and hundreds of causes which can cause tropical infections of CNS, which include viral. I wanted to cover, but I think I will not be, though I have made almost 30 slides for that. Then comes bacterial, all of you have seen and managed them. Tuberculosis, which I will be discussing in detail. Parasites, large number of them, malaria, neurocystic sarcosis, this and that, acanthamoeba. We see each and every type, but probably we will not be able to discuss. And then most important and still commonly missed are the fungal infections, which are potentially lethal and need to be diagnosed in time. So let us see how much we can approach. And so if you see this busy slide, it is full of organisms which can cause febrile encephalopathy, and this list is still incomplete. So I will not be discussing each and every infection, but many types of viruses, bacteria, rickettsia, fungal, parasitic infections can lead to febrile encephalopathy. And this is the two important series from children and adults from India, which show that viral encephalitis probably cause an important chunk of febrile encephalopathy in children, followed by bacterial and then tubercular. While in adults, it again 70% have infectious causes, and of these 33% had meningitis, 29 had meningoencephalitis, and then there is a large number of causes which can cause febrile encephalopathy. So we really need a holistic approach. In a patient who has presented to us with fever, altered sensorium, with focal signs plus minus seizures, and of course The most important remains history. I'll not be going into the details, but the important being in which season the patient is coming, whether it is a season of malaria, dengue, chikungunya, Japanese encephalitis in the post-monsoon season, recent travel across where the person might have acquired some infection from over there, then any infection or vaccination in the recent past, then whether the similar kind of, as we see that many of the viral infections or viral epidemics, they come in clusters. So if a community is experiencing a new onset febrile encephalopathy, we commonly implicate it to a virus which has come in that community, and we accordingly work on it. And then importantly, as somebody discussed earlier, rabies is important though missed. If time permitted, I'll show one or two cases. Then brucellosis is also an important common differential diagnosis of tropical CNS disease, which can mimic fungal and tubercular CNS infections and should be should be actively sought and should be ruled out if your patient is not responding to treatment. Then tuberculosis remains an important and underdiagnosed, I will say, or diagnosed late in our community. And of course, history of AIDS or syphilis. Then once you have an HIV positive, the list of differential diagnoses, they change according to your clinical judgment and to your CD4 counts. And then same is true with immunocompromised people post-transplant, or people who are on immunosuppressives, or people who are on chemotherapy. They have a different set of infections, and probably the time will not permit to discuss all of them. But cryptococcosis, varicella, CMV, toxoplasmosis, and for that matter even tuberculosis, they commonly cause serious and fatal infections in these settings if they are not diagnosed in time. So with this background, how are we going to go ahead with the evaluation of febrile encephalopathy? After a good history, we are able to now examine and see if the patient has evidence of meningitis in the form of Cunning sign, Brodzinski sign, jot accentuation. We look at the skin and mucous membrane for petechiae or purpura. We look for lymph nodes, liver, spleen. So these goes without saying that a thorough general physical examination is important to point out towards a particular diagnosis clinically, because all patients will come to you with 3 or 4 days of fever, headache, and altered sensorium with or without seizures. So examination, neurological examination should particularly focus towards fundus, cranial nerve involvements, especially bilateral 6, which you can see even in a comatose patient also, evidence of third nerve involvement with pupil asymmetry, and then focal deficits, brainstem signs, autonomic dysfunction, whether there is any evidence of flaccid paralysis, and some kind of movement disorders. All these neurological signs and symptoms will point towards a particular diagnosis and will probably guide you towards a particular list of investigations which you should go for. So not going into detail. So on general examination, you may find some clue towards a particular diagnosis. If you have got, say, for example, jaundice and hepatosplenomegaly, you may think in terms of dengue and chikungunya, especially if there is endemicity or it is a season for the same. And same is true for looking for rashes, parotitis, pneumonia, and of the investigations, I must want to emphasize that it is CSF is one most important investigation, but short of that, one should not ignore the total leukocyte count, the differential leukocyte count, and the importance of blood cultures. I'll show it in one of my cases. And of course, the biochemistry, the renal function test, liver function test. What I meant is that the general workup should be complete in any patient of fever and any patient for that matter with febrile encephalopathy. I need not emphasize the importance of the basic investigations, which also include urine analysis, a good chest X-ray, an ultrasound, and of course, as a neurologist, and after everything has been worked up, a patient is lying unconscious, lumbar puncture remains the investigation of choice, and we'll discuss what all we can do in a lumbar puncture. And of course, neuroimaging or CT and MRI is the backbone for making a correct diagnosis in any patient of febrile encephalopathy. Though we do emphasize the role of EEG, especially in certain infections, but it is, it is not 100% requirement. But a good routine examination, routine cultures, routine biochemistry, a good lumbar puncture, and neuroimaging are the backbone to make a correct diagnosis of a patient with febrile encephalopathy. So this is important. When should we do? Lumbar puncture is something which has to be done on an urgent basis. You can't, because it is always good to, start empirical treatment after doing a lumbar puncture so that you are wiser. You get the organism. You are able to find out the bug. Because once you give the first dose of antibiotic, then probably your yield from lumbar puncture in isolating the organism is, at times missed. So, but in the meantime, if you have to do neuroimaging, then probably you will not wait for the treatment to be offered to the patient who is already in a bad state. But certain situations, like in immunocompromised state, in patients with mass lesion, stroke, or focal deficits, new onset seizures, evidence of cross papilledema, and a comatose patient and patient with focal neurological deficits, and especially immunocompromised, they should undergo at least a CT, if not MRI, before we do a lumbar puncture to avoid any herniation and sudden death. Without fail, it is important to note that MRI always yields much more information compared to a CT scan, but it may take time, and CT may be needed to rule out, or to rule in certain hemorrhages, in certain infections, abscesses, or raised ICP, or any mass effect, or things like that. Or for that matter, if you are seriously suspecting tuberculosis and you find hydrocephalus and basal exudates on a contrast CT, probably you are almost sure that you are dealing with tuberculous meningitis, and you can wait for MRI for a later time after stabilizing the patient. So as I told, CSF remains the backbone for diagnosing most of these conditions. This is a routine table which is, discussed in every forum, but importantly, still, just by looking at cells, proteins, and sugar, you come to know what you are dealing with. If your sugars are normal or essentially normal, probably you are not dealing with pyogenic or tubercular meningitis. It is simple viral infection, even though you can have lymphocytic pleocytosis with raised proteins. So that is the importance of but importantly, you must get a corresponding blood sugar along with to say that the sugars are normal, right? And of course, if we are thinking of bacterial, usually the counts are, I'm always using the word usually. It doesn't mean that if it is less than 1,000, it cannot be pyogenic. It can be with even 60 cells also if it is partially treated pyogenic meningitis or a patient is immunocompromised. Then in tubercular, you can have variable cells, 100, 200, 300, 500, 1,000. It can be any, but it is usually in the range of 100 to 150. It is predominantly lymphocytic. So everything is predominantly. So these actually give you a clue towards a particular direction, but they are not something absolute. In fungal, you have lymphocytic, and bacterial, you have polymorphonuclear. But then you can have polymorphonuclear in any of these conditions. That doesn't straight away, you cannot jump to the conclusion that if they are polys, it is only bacterial. It can be other infections also. And so we rely on all the three parameters of raised proteins, low sugars, and lymphocytic versus polymorphic pleocytosis, and of course we send for all the workup that includes gram stain, gram cultures, fungal smears, and for that matter even for AFP, which commonly we don't get, and even for that matter cryptola is something which is commonly done in our center and should be done in every center for that matter. You never know. Sometimes the patient may not be giving you a chronic history, but he or she may be having low grade thing going on and they ignored it, and the relatives will just come to you with 2 or 3 days history, and if you find out they may be carrying history for weeks or months together. So at times once you are seeing a patient in comatose state, you may not get an acute history and you may miss the diagnosis because of the improper history given by the attendants, because the patient is comatose. So, and then there is an emerging role of multiplex PCR, what they call as BioFire ME panel, meningoencephalitis panel, which detects 14 organisms, though costly, but has come as a standard of care in the patients, especially who can afford, but probably not available in most of the government setups. It is available in the private setups, and in government setup, we still commonly go ahead with the routine cytology, with the routine biochemistry, and with gram stain, gram cultures, as I told you, fungal smears, and of course, we send, if this index of suspicion is really high. And for that matter, in most of our patients, we are sending them for Gene Expert Ultra, Gene Expert vis-a-vis Gene Expert Ultra, whichever is the facility which is available. And of course, we send it for India Ink and fungal smears also. So that is how, actually any patient who is in altered sensorium with fever should be worked up for and should be managed accordingly. So viral meningoencephalitis remains one of the important causes of febrile encephalopathy, and in our setup it is primarily Japanese or herpes simplex, but then there are a number of emerging viral infections which are coming up these days. I'll start with a very interesting patient. He was a 57-year male who came with just 1 day history of febrile encephalopathy. That time he was M5 when he presented to us. He had terminal neck stiffness, pupils were normal, reacting equally. He was moving all 4 limbs. CSF showed 600 cells, all polys, proteins were raised, sugars were low. As you can see with the corresponding blood sugars, they were really low. But the gram stain culture was negative, AFB, Gene Expert, fungal smear, crypto, line yank, everything was negative. So he was diagnosed as a case of pyogenic meningitis, and he was treated with empirical ceftriaxone vancomycin. However, despite starting treatment, this patient deteriorated to M1 state and he needed ventilator. This is the MRI. So that was the CT which was not showing any hydrocephalus. Now look at this MRI which is showing hydrocephalus, and there are certain changes in the brain stem, as you all can appreciate. And then if you see the contrast, there is diffuse meningeal enhancement and there is some basal meningeal enhancement also. So the knee-jerk reaction with such a case is always that, so what are the possibilities? The first and foremost which crosses your mind is, are we dealing with tuberculosis, or are we dealing with some kind of a fungal infection, amoebic encephalitis which will manifest same way, or it's still a viral encephalitis because of those brainstem changes, or is it some lymphomatous disease or some kind of a vasculitis which is producing brainstem changes, or some kind of a neurosarcoidosis which can, especially Behçet's, that can produce with brainstem signs and these kinds of features. So, but to our surprise, the blood cultures fortunately revealed Listeria monocytogenes, which was isolated. So that is why I was emphasizing that before starting antibiotics, it is important to do all the workup of a patient with febrile encephalopathy, like a fever, which includes blood cultures if the patient is unconscious and you are planning to give antibiotics. And now, after this, the patient was started on ampicillin and meropenem. He underwent external ventricular drainage and then shunting, and then he improved to the tune that he was M6. We continued the treatment for 14 days. Repeat CSF showed no cells, and the proteins and sugars started normalizing, and this is the MRI of this patient. Neat and clean brainstem now, which was hyperintense in the background. So why I discuss this case is that isolation of organism, especially when you are talking of bacterial meningitis or pyogenic meningitis, of utmost importance, because especially in Listeria, they may not respond to your empirical ceftriaxone therapy, and ampicillin is the drug of choice. And that has to be in your mind when we are, treating patients, especially elderly, with febrile encephalopathy and picture of pyogenic meningitis. So that was one important take-home message for us also and for all of us. So coming to the topic of interest given to me was, if we can identify, he's Robert Koch, who, a German physicist who discovered tubercle bacilli long back, almost 150 years back, but still this bug is, though centuries and centuries old, but still, bugging us even today. And we have still an epidemic of tuberculosis, and we don't see any light to eradicate it by 2025, though the government is trying really hard. And all of you are aware, I'll just fly through my slides. We are aware that is how CNS manifestations of tuberculosis are. It's leptomeningitis, tuberculomas, cerebritis, encephalitis, myelitis, and whatnot. So it's a great mimicker and can produce. So looking at this picture, anybody and everybody can diagnose tuberculous meningitis with lot of basal exudates and hydrocephalus. And this is the classical spider web appearance, which anybody will see and say, no, it is nothing but tuberculosis. Well, it is good to diagnose tuberculosis based on this imaging, but look at the condition of the patient. He must have gone from stage 1 to stage 2 to reach this stage when he was undiagnosed. So to diagnose patient of tuberculosis or tuberculous meningitis at this stage is no big deal, which we are doing in tertiary care, which is of no use. So we probably missed the softer signs and probably inappropriately treated this patient in the initial few weeks that he landed in this situation. So diagnosing a book picture of tuberculosis is anybody's job. Anybody can do it. So this is just, I want to show you the spectrum. You can have border zone encephalitis, where you will have exudates and then surrounding edema, which produces lots of intractable seizures. Then you can have arthritis, which can produce infarcts. You can have tense basal exudates, and which can cause vision loss and many cranial nerve palsies. Like in this case, we have got third nerve, which is enhancing. Then in this case, we have got bilateral vision loss because of complicated tuberculosis or tuberculous meningitis, producing lot of tense exudates and causing just crushing of the, this is the autopsy of the same patient. He succumbed to the illness, and it was really difficult for the dissector to remove the tubercles and separate it out from the optic nerve. They were so thick, so dense, and it just proves that probably the disease was evolving and we could not diagnose him in time, and he succumbed to it. So the complications are, of course, hydrocephalus remains most important, and then border zone encephalitis, as I showed, infarcts, and arachnoiditis. I'll show each of them. So I just wanted to know from the house, if anybody can tell, what is the mortality in stage 3? The mortality is more than 40%. What do you mean by stage 3? In stage 1, when the patient has meningitic symptoms and a good CSF analysis could have picked it up, is usually lost when the disease is mild, patient is conscious, and there are no focal signs. Even in moderate, still there is a ray of hope. The patient has altered sensorium, but not comatose. He has moderate deficits and maybe a single cranial nerve or so. Even if we diagnose at this stage, still the outcome is good. But when we see a patient who is severely comatose with multiple cranial nerve palsies, the outcome is really bad. And this is the kind of mortality. Close to 80 to 90% of mortality in stage 3 with advanced disease. So no therapy really works in that stage. So we always aim to try to diagnose TBM in stage 1. So the mortality depends not only on the virulence or immune response, it is mainly the delay in the diagnosis which contribute to. MDR tuberculosis, commonly discussed, forms less than 3 or 4% of the total TBM cases. And don't say it's not an important disease burden, it is. We see almost 100% mortality with MDR tuberculosis. Just one case is surviving in hundreds of cases of TBM with MDR tuberculosis. So it is uniformly fatal, I agree. But main fatality is because of the delay in diagnosis. And this is what our paper also suggests, that presence of stage 3 disease or hydrocephalus is definitely, and with focal neurological deficits, is associated with poor outcome. So there is problem of early diagnosis, treatment, persisting lesions, and role of immunomodulation. I'll just go through one by one. How to diagnose TB early? It is always a clinical suspicion, CSF, neuroimaging, evidence of tuberculosis elsewhere, and exclusion of alternative diagnosis like fungal, right? So I'll not go through all the criteria. The smear is because it's a very insensitive, usually we don't get it. Cultures take time in non-LJ. Of course, with MGIT, that culture time is less than 2 weeks now. ADA is not considered a good investigation. PCR, especially the gene expert, this is the MGIT, where you get cultures in 10 to 14 days, and this is how you find out, and you can do culture insensitivity also. That was the LJ medium, which takes 4 to 8 weeks. And then gene expert or gene expert ultra definitely helps in diagnosing, but that doesn't rule out tuberculous meningitis. That is an important thing. If gene expert is negative, that doesn't mean it is not tuberculosis. Gene expert ultra has a shade better sensitivity, but also that doesn't rule out. So the index of suspicion has to be high, and these tests are only to help you in making a better diagnosis or finding out rifampicin resistance. That doesn't stop you from diagnosing TBM and treating it in time. Though other parameters have to be taken. If you are suspicious, go for CT chest abdomen, look for evidence of tuberculosis elsewhere. Then comes treatment. We are still using the age-old regimes, and rifampicin came to our rescue way back in 1963 or in 1970s. PZA came, and for last 50 years we are on the same regime without much breakthrough. So still those 4 or 5 drugs remain the backbone, and I just wanted to know you all that which is the drug which is most CNS penetration. It's not rifampicin. It is either INH or it is pyrazinamide, which actually penetrates the CNS even in non-inflamed meninges also. So these are the dosages, all of you know better than me, but we prefer ethambutol, especially in stage 3, because of the complications of optic neuritis. And because we are extrapolating the pulmonary guidelines, so the guidelines for tuberculous meningitis are still not there. CDC says for 6 months, WHO says for 9 months, UK says for 12 months, American Academy of Pediatrics says 9 to 12 months. The index TB guidelines of India say that you can extend it by another 3 to 6 months, meaning thereby that you can go up to 1 year in a given patient of tuberculous meningitis, and with an intensive phase with RHZD and a continuation phase with ethambutol. Though we as an expert group always debated it that ethambutol is of no use, it is not going into the CNS, it is not helping us in any way, and if at all we should use pyrazinamide. But no, it has become more of a individual guideline. It's not a national guideline. So this is just our experience that ethambutol may not be of use, and at least 12 months should be there. And then people are asking about the use of quinolones. Wonderful drug, has excellent penetrability, but the studies have really not shown much advantage. One reason can be that quinolones are probably very abused drug. We see almost 20% resistance in our series of patients who are culture positive, and they are 20% are quinolone resistant. That's why probably we are not getting the kind of results we should have got with quinolones in patients who are being empirically treated as a first line also by many of us now, because of the serious nature of this disease, which I felt was possibly justified, but probably we need something more than just these 4 or 5 drugs. But that needs a lot of trials which are still going on. Until the time we have a scientific evidence, I really cannot give you a clear-cut data to suggest that we should use linezolid or ethosuximide or ethionamide in the first line as of today. Maybe after 2 or 3 years, once the results are out, we may be able to give better guidelines of managing CNS tuberculosis in a different way from pulmonary tuberculosis because of the availability of these entities in the CNS or their penetration. I think rest I can discuss during the discussion because it's a long topic. Just one thing I just wanted to tell that when we say that the patient is not responding, or the patient, say this patient who presents with recurrence of lesions or new lesions, it may not always be MDR tuberculosis, it may be an immune response. Just like this patient who has got an extensive arachnoiditis after starting treatment, or this patient who developed vision loss after started on ATT, and look at the exudates. So that doesn't mean that the patient has MDR tuberculosis. We can see the worsening, we can see the increase in the lesions after starting ATT 3 months down the lane. So this may be an immune response, and it needs immunomodulation rather than changing or switching over to second line drug. So we do use thalidomide in our cases. Some people use infliximab, though it's costly. People have even advocated cyclophosphamide also, but it becomes more of, your experience. And at times, you have to really send them to a higher center for proper management so that we don't miss MDR and at the same time, we don't mismanage with second line therapy. And I think I stop my talk here and invite some comments and questions.
Thank you. Thank you, Dr. Modi, for an excellent talk.
Thanks.
Nicely done. Managing CNS tuberculosis is always a challenge, and it is difficult to discuss everything in 30 minutes time. So now we can have one or two quick questions from the audience.
No doubt about the role of steroids, absolutely no doubt. But in HIV positive, there are still trials going on. The major trial, it was, Thwaites trial. Guy Thwaites did the first trial, published in NEJM, which gave the evidence beyond doubt that steroids are needed and indicated in every patient, and higher dose with longer duration in stage 3 TBM. But they have not yet published their trial in HIV with TBM, where probably the results are not that encouraging and probably not indicated upfront as a first line along with the first line ATT. Which cases? So as I told, for stage 3 we are going up to 3 months. Otherwise, we usually give it for 6 to 8 weeks.
Thank you, Dr. Modi, for excellent and comprehensive review of neuroinfections. Let us all give him a big round of applause for the excellence. Thank you so much.
Thank you, sir. Now I request the faculty to kindly proceed to the felicitation desk. I request Dr. Ashok Grover to felicitate the chairpersons and speakers. Now I would like to invite Dr. Anupam Singh to start with the next session.
Good afternoon, everyone. Next topic is a very topical topic. It is one of the, in last decade, one of the major advances has been multiplex panel and PCR diagnostics. I'll be calling over Dr. Shalab Malik, who is the lab head from Lal Path Lab, to elucidate this topic to our audience. I would also be inviting chairpersons, Dr. P.N. Chaudhary, Senior Physician, Max Vaishali, Dr. Meenakshi Jain, Senior Physician, Max Noida, Dr. Saloni Sehgal, she is a Senior Consultant at Max Vaishali, and Dr. Sanjay Mahajan, he is a Senior Physician at Max Noida, for this interesting topic. Please.
Yeah. Thank you, Dr. Saab, for kind introduction, and I am thankful to EDPA, Dr. Makkar, Dr. Swati for inviting me for this talk. So today I will be talking about panel diagnostics and multiplex PCR testing, which is a vast topic because there are now so many testing available. So I will be giving you brief overview about it and how we can judicially use it. So we are in the era where we are talking about diagnostic stewardship, which means right patient, right test, right time. And this leads to antibiotic stewardship. So the days of guessworks are over, and we can practice the precision-driven medicine with the help of this multiplex type of PCR testing. So infectious molecular multiplex assays are a type of diagnostic test used to simultaneously detect and identify multi-pathogens in a single sample. So anything more than one. So we have now vast multiplexes available, ranging from the type of syndromic diseases like meningoencephalitis, gastroenteritis, pneumonias, respiratory illnesses, etc. And then there are sub-multiplexes also available. Now look at the TB XDR panel, which has come from the CEPHID group. So there are then STD panels. So likewise, there can be n number of multiplexes which are available. But due care is taken that they don't cross-react and give you the misinformation. So it helps the simultaneous detection. That is the biggest advantage. Pathogen identification, it classifies beautifully whether you are dealing with bacteria, virus, fungi, and parasites. As far as sensitivity specificity is concerned, is excellent, more than 90-95% in most of the cases. Cross-reactivity is taken care of so that you get the genuine results. And when we talk about the panel customization, it is not possible when you are talking about the commercially available multiplexes. So that can be done at a lab-developed test level, or a smaller multiplexes can be developed over there. So what are the challenges with the traditional methods? So we all know it is time consuming. Now suppose you take the CSF out, you will be sending for cytology, cultures, routine stains, maybe some PCR, and then few of the tests will not be available in the hospital itself. So you will be sending to some reference laboratory which will be running it on a scheduled basis. So you don't get this thing urgently addressed. Whereas we are in the era where the test which can offer you a result in less than an hour's time is a medical decision changeover. So limited information you get in the traditional methodologies, difficult to culture fastidious organisms, subjectivity to interpretation, contamination is another concern, and on the contrary, these advanced methods will offer you a rapid simultaneous detection of multiple pathogens in a one go. So primarily I am going to highlight more on the biofire, because this has changed how we practice the medicine, how we drive home the precision-driven medicine. So with syndromic testing, it is possible, increases the probability of identifying the pathogen using the right test, right first time, and reduces the guesswork, reduces the cost. Somebody said that it has a huge cost. Now, if you look at what is happening before this test, and even now in majority, we go for the empirical regime, where antifungal cocktail of antiviral cocktail of the last generation antibiotic does not cost less. And then you are harping in the dark, and look at the n number of tests which I listed in the conventional site. So now add up this cost and compare to this, it out in time where you will be targeting the bug rightly. So aids in a proper management, including the admission, isolation, cohorting, and treatment therapy. So on the other hand, without this type of test, the infectious cause remains unknown, the right test may not be ordered, the wrong test or no test may be ordered, cost associated with additional testing, patient care may be compromised, and risk of adverse outcomes and patient dissatisfaction is the thing. So where are we going to apply this? Now you can apply in all age groups, across all outpatient settings, but it is the emergency departments and the hospitalized patient, it is a game changer where it will influence your treatment. So let us quickly look at what is available. We have got all this biofire ME panel, pneumonia panel, respiratory panel, GI panel, and the latest in this entry is joint infection panel. Now this is highly unexplored territory. So you do culture, you do stains, you do cytology, most of the time answers are nil. So this pinpoints the bug because it is addressing both aerobic as well as fastidious anaerobic organism, and you can do the targeted therapy. So as far as ME panel is concerned, it tells you about the bacteria, viruses, and fungi. So bacteria is from E. coli to Haemophilus, Listeria, Neisseria meningitidis, Streptopneumonia. Even the simple bugs like Streptopneumonia in our country, if you don't have a right atmosphere, you don't have a CO2 incubator, you are going to miss it. You won't grow. Then viruses, CMV, HSV, HSV6, HSV2, human virus, enterovirus, varicella zoster, etc. Now some of these viruses, if this is detected immediately, you can resort to antiviral therapy. And then on the other hand, enterovirus requires no therapy at all. It requires supportive management. Fungi, it is Cryptococcus neoformans. So overall sensitivity and specificity is good, and these are all, you see, FDA approved tests. Now once you get FDA certification, you have to undergo a thorough grill that is cross-checking with the so-called gold standard like cultures and whole genome sequencing is carried out. and also cross-reactivity with other viruses, other bacteria is done before it is available in the commercial market. Now, in biofire pneumonia panel, it covers all your routine bacteria as well as the atypical ones, chlamydia, legionella, mycoplasmas, viruses, adenovirus, coronavirus, influenza A, B, RSV, etc., and resistance genes also. Now, the beauty about this panel, when I am talking about the routine bacteria, it gives you a quantitative value also. So, the quantitative values range right up to 10 raised to power 7 bin. Now, what we have seen, especially 10 raised to power 7, 10 raised to power 6 correlates well with the culture. Culture also you will get a substantial amount of the growth. So, it is quite accurate. It is an hour's job. 33 targets are addressed, and also if you are getting the bacterial bugs, you are getting a parallel commentary on the drug resistance genes also. So what happens ultimately, one of the CDC funded study was carried out on 2488 pneumonia patients, and what they found that in conventional therapy it was 62% no pathogen were detected and others were detected, whereas it is vice versa when you take the help of the biofire type of multiplex. So definitely you are going to get much more yield, much more pathogens will be reported because we are going to hit at a nucleic acid level. So almost the yield doubles and triples what we have seen in the case of BAL versus sputum. Now next is the RP panel, that is respiratory pathogen panel. So adenovirus, coronaviruses like HKU1, NL63, 229E, OC43, human metapneumovirus, rhinovirus, influenza A, H1S3, A, H1 2009, influenza B, parainfluenza 1 to 4, RSV are detected. And along with it, Bordetella, chlamydia, and mycoplasma are picked up by this test. Then GI panel, as in earlier talks, it has already been stated the importance about the GI panel in the diarrheal disease, in the chronic diarrheal disease, and especially certain special settings like renal transplant or chemotherapeutic units. Then the new in the entry, as I said, is the joint infection panel, which covers your all anaerobes as well as aerobes, Anaerococcus, Clostridium, QT bacterium. See, all these bugs you are going to miss on the routine culture. And Staphylococcus lugdunensis, Streptococcus agalactiae, etc., Bacteriophagelis, Klebsiella grove, other gram-negative, Neisseria gonorrhoeae, Salmonella, Serratia, etc. are covered. And along with it, you get a commentary on the carbapenemesis, ESBS, MRSs, vancomycin, etc. So what happens? So once you know the exact thing, what you are going to hit, immediately you can alter your antimicrobial. So it gives you the potential for antimicrobial de-escalation, and up to 50% of the patient could have had an antibiotic de-escalated had you used this panel. So definitely it fine-tunes your therapy. And the biofire pneumonia panel could have saved more than 18,000 hours of antibiotic use, and naturally the unnecessary antibiotic and related collateral damage because of the C. difficile toxin and all can also be avoided. So now these genes are also answered. So now the newer BL-BLI combinations are available with us. So how to use, what to use. Suppose India, which reports maximum of the New Delhi metallo-beta-lactamases. So there the new thing, that is ceftazidime avibactam, is not going to work. Then we have got, suppose ESBL has come positive, then ceftazolone tazobactam, ceftazidime avibactam, meropenem vabrobactam are going to work fine. So the information about these genes helps you in taking a precise decision which newer BL-BLI combination you are going to target. So what is the concordance of AMR gene markers and organism with the conventional test? So this concordance is good. You are getting quantitative values also, as I said in the case of pneumonia. So it will be good practice if you combine it with culture, where you can further fine tune it and look at it. So one word of caution is there that suppose multi-bugs are detected, let's say Klebsiella is also coming, Citrobacter is also coming, Proteus is also coming. So the question in your mind will be from where you are getting this gene. So unfortunately, it can't differentiate. It can give you a general idea that, okay, look, AMR gene is very much there in this. And you have to be cautious in selecting your antibiotic. So are PCR positive, culture negative samples clinically significant? Yes, it is going to happen, because see, we are talking about the nucleic acid levels, and the culture, what happens, fastidious organisms you are going to miss. Then there is the issue of overgrowth of the other pathogens. So maybe they are hidden below it, and sometimes it will present as a mixed picture. So which will be commented by the lab as a no pathogenic organism grown or commensals grown. So you have to view it in totality, take into account clinical features also, and other possibilities before you look at it. Definitely, it will never be one-to-one concordance, but whenever you see the PCR report telling you that it is 10 raised to power 7 or 10 raised to power 6, then it is very much relevant as what we have observed in parallel with culture examination. So discrepancies could have been caused by fastidious pathogen that is difficult to culture. Culture results could have reported normal oral flora, as I said. The biofire pneumonia panel should be used in conjunction with the entire clinical picture and including culture results. So finally, we are going to see huge economical impact. There will be reduced turnaround time. So especially you have someone in your emergency room, or you have hospitalized today, immediately you order this test and you get the quick answer in 1 hour's time. Duration of antibiotic therapy is decreased. You have fine-tuned your antibiotic. So unnecessarily pumping of antibiotic, antivirals, antifungal, etc. is negated in case of ICU type of settings. So finally, diagnostic stewardship, which is the hallmark of this testing, helps you take a step forward towards the antimicrobial stewardship. So then other question in the mind is issue of co-infection. Now suppose you have sent a CSF or ME where you are suspecting ME panel, and you get a enterovirus and E. coli, or let's say HSV and E. coli. So definitely they are relevant because these are not a normal flora. And I believe all precaution has been taken while collecting the CSF sample during the lumbar culture processes. There are some cautious situation, like suppose the collector has been careless and maybe he's having some herpetic lesion on his finger, etc. So we should not forget that these are the nucleic acid type of test, highly sensitive, and they may contaminate and all. But then if doubt is there, you can always subject it to further testing, because these answers are not quantitative. So never ever use these for monitoring your treatment, because these are qualitative and these are meant more for the emergency setting or where there is a no diagnosis has been arrived or a condition is recurrent, etc. So if that is the case, you can ask for quantitative studies also. For a, let's say if herpes was detected and you are doubting it, you can subject it to viral quantitative herpes studies. So that can answer this. Then other limitation of these panels are that you are going to answer whatever targets are fixed in this. So anything beyond this is there. For example, Japanese encephalitis we are talking about, it is not there in this. Or other pathogen we are talking about, let's say in the case of pneumonia, Stenotrophomonas, it is not covered. So you will have to take help of other investigations also. So
kindly
finally,
conclude, sir,
finally, you have to emphasize on the synergies of this co-infection and take your decision accordingly. Now, for example, influenza, pneumonia, or cytomegalovirus, pneumocystis jirovecii. Cytomegalovirus is a further immunosuppressant. And if pneumocystis is also detected, it is going to further flare up. So you have to be watchful about the synergies of this co-infection and take a decision accordingly. So let me quickly take you through my data. Now let's look at the ME panel. So here E. coli was the commonest which we picked up on this multiplex PCR, followed by H. influenza, then Streptococcus pneumonia, then herpes simplex virus, and Cryptococcus. So these were the top 5 common which we found in our analysis of these past 6 months in 274 samples of CSF. Then let's look at the pneumonia. Mixed infection was seen in 25% of cases. Haemophilus influenza, 11.8%. So surprisingly, after COVID, even on the culture, whenever I'm seeing culture, sputum, ET secretion, etc., Haemophilus has become quite popular, and we are growing it. We are reporting the sensitivity of this. And unfortunately, if you don't have a good media, good atmosphere of carbon dioxide and all, you are going to miss this bug. So then influenza AB on the virus front, human rhinovirus, adenovirus, Acinetobacter baumannii, Staph aureus, etc. were other bugs which were picked up. Then in RP panel, RSV was number 1, followed by influenza A, parainfluenza. Then corona, of course, we are seeing a decline now. And 1% cases we found Bordetella pertussis, parapertussis also. Then on GI front, it was enterotoxigenic E. coli. GI front, see, we have to be very careful. The stool has to be really loose. You should not conduct the study on well-formed. It is a meaningless exercise. So symptom, by a good watery stool or at least unformed stool should be there. So enterotogenic salmonella, rotavirus, giardia, norovirus, campylobacter, ceprovirus, etc. were picked up on this panel. So finally, primary outcome is duration of time, inside room isolation. Secondary outcomes are turnaround time of results are reduced. Percentage of patients with pathogen detected are definitely more in number compared to the traditional studies. You are going to use appropriate antibiotics. Time to choose appropriate antibiotics has been significantly reduced, and of course, duration of antibiotics also influencing the length of stay, and finally, adverse outcomes are reduced. So thank you for patiently. Thank you.
So thank you, Dr. Seller, for highlighting the very important aspect of this multiplex PCR. And we all know that we are struggling with antibiotic resistance globally, right? And we have a patient right now admitted with us, coming from different hospital. Pseudomonas grown in the culture, it is pan-resistant. So this is a common scenario which is going nowadays. I think this would actually help us to actually isolate the organism in the right time, so that timely treatment should be initiated. And you are rightly said that now it is a precision-based medicine is more of the important issue regarding the treatment. So I think have a comment from the our co-chair, and then we'll close it because time is running short.
See, cost, if you look at the cost per se, definitely it is more when you compare to conventional testing and all. But if you look in totality, how many investigations you are going to order and the time factor, and then the cost of empirical medicine. Yes, specifically it is around, I think, 15 to 18,000 rupees, something like that.
This was the microbiologist perspective of the story. The clinical part, what we've been seeing. See, in tertiary care hospitals, we all have the biofire panel available nowadays. And it has really helped us. 15,000 when we talk about ICU care, and once we have to decide an antibiotic, a single dose antibiotic could cost 15,000 rupees. So, and within 6 hours, if you could get a bug, and you could actually decide whether to be very stringent on the right type of bug, gram positive, gram negative, it does definitely cut on, with initiation of antibiotic, with every hour lost, we know the first few hours, the mortality increases, multiplies in fact. So an initial antibiotic, the right dose, the right antibiotic, if we start, the cost of hospitalization tends to go down. And as Dr. Saab rightly pointed out, that we could actually de-escalate antibiotics at the right time. So this has been helping us all in the clinical practice. So the cost upfront, it would sound 15,000, but it is actually very effective. Dr. Meenakshi?
See, the most important aspect of this is the viral infections. There is no way to detect viral infections in the cultures. So there are many of respiratory infections which are viral infection, which we treat as bacterial infection, and we keep on treating, thinking that it is multi-drug resistant bacteria, but instead it comes out to be viral infection, number one. And secondly, it is the meningitis, meningoencephalitis panel or ME panel, because lot of viral infections are causing meningoencephalitis, and they are being treated as bacterial meningitis for long duration of antibiotics, number two. Thirdly, the GI panel and the eye panel, the joint panels are also giving us information. But right now, most commonly and most, I think, informatively, it is being used in ME panel, meningoencephalitis panel, where we can actually pinpoint the cause of encephalitis and meningitis. Thirdly, another thing is that not all the bugs are covered in this. So sometimes a negative PCR multiplex gives us a false sense of security. So not fungal infections are not well covered in all these multiplex panel. So do look for fungal infections separately. Secondly, these multiplex panels are not very accurate because they are using primers which are multiple primers for multiple sequence, and techniques of doing it is also with multiplex, rather than doing a uniplex PCR is not that accurate. So sometimes we tend to get 5-6 organisms and it does not make any sense. So it is not that a negative multiplex rules out all the infection, because many bugs are not covered. Secondly, it could be a false positive also, because few of the viruses and few of the bacteria may not be, they can give a false positive result. So what is your comment about the specificity of the multiplex panel in comparison to a uniplex panel?
As far as BioFire is concerned, you must be aware it is FDA approved, and it has been thoroughly checked across cultures as well as whole genome sequencing and cross reactivities also. So coming to the second point, that what to do when 5-6 things are detected, this happens especially in the case of stool or pneumonia sample also. So look at the sample quality, cross-check with the gram stain and all, what the picture is telling you. And sometimes person-related contaminations also happen. Now suppose somebody is suffering from pneumococcal infection, or maybe herpetic whitlow is there on the finger, and you have not taken proper precaution while collecting. Or technician has committed blunder by putting this sample inside the... Yeah.
These are very helpful and very informative, but always correlate.
Yes.
Yeah, we can deal with other questions.
So thank you so much. Thank you.
Later.
Thank you very
sir, for such an informative talk.
Thank you, sir. I request the speaker and chairperson to proceed towards the felicitation desk.